and I'm President and CEO of Angioma Alliance, and it is so great to be here and to see everyone in the room, and I'm happy everybody came. We always worry when they're free conferences that folks aren't going to show because there's no skin in the game, and like if it's a beautiful day, it's hard to justify being in a room for 3 hours in the afternoon, but you made it, so that's awesome, and I think we're going to have some really wonderful presentations for you today. Also, how many people here are patients at UCSF rather than Stanford? Are there any? 1, 2, okay, 3. All right, after the break, we're going to have a special announcement and presentation ceremony, and if the folks that are UCSF patients would like to be a public part of it, we would love to have you. I have photo releases for you to sign if you are willing to let UCSF use your picture. And just so you know, get with me at the break and we'll get that all set up. Where are the lavatories, Stephanie?
They are go out to the main office and go left all the way down the hall. You'll see a sign that says restrooms that way.
Okay, so Stephanie just let you know where they are. And we are going to have, just so you understand, the agenda is we'll have 2 talks, we'll have a break, and then we'll have 2 more talks, and then there will be an opportunity for you to ask questions. We're recording this as a webinar as well, so there may be some questions coming from the people who are watching at home. And that'll be kind of interesting for us too. So without further ado, I'd like to introduce Dr. Nerissa. She is a neurologist at the University of California, San Francisco. She is I'm going to scoop my announcement. She's going to be the co-director of the Center of Excellence at the University of California, San Francisco. We're going to be presenting them their certificate today, later on, and she's going to share with you CCM 101, the basics of cavernous angioma and what you need to know if you're just coming in late.
No, that won't work, right? That's
I don't know.
Yeah.
Good afternoon, everyone, and thank you so much to Connie and the Angioma Alliance for inviting me to speak with you folks today. Can you hear me in the back of the room? It's hard to tell with this mic. Okay, wonderful. And yes, I echo that it's such an important thing to come together as a community and spend your afternoon, and maybe just because it's too hot out there, it's actually nice and cool in here. We'll enjoy our time together this afternoon. As Connie mentioned, I'm one of the neurologists and neurointensivists at University of California, San Francisco, and we have really wanted to be part of this community for a long time, and I think even though we've taken care of many of our patients, having kind of a partnership with the Angioma Alliance is really wonderful to make sure that we're aligned well with what you folks really need and expect from us. So I know many of you in the room probably know some of this, but for those who don't, it'll be a review and hopefully an introduction to a very, very complex disease that we all are on a journey with together. So I'll just get started. Okay, so just, in the sense of overview, vascular malformations are a large group of abnormalities in the brain that deal with blood vessels. And you probably have kind of heard about all these other ones, and just to put it into context, right? Vascular malformations encompass things like arterial venous malformations, which are an AVM, kind of picture on this side, CM, which is the abbreviation for cavernous malformation, a dural AV fistula, another kind of subset, venous malformations, capillary telangiectasias. These are just kind of the top list of things. And so already, how difficult to navigate for physicians, radiologists, much less patients and their families. So, thinking of this as a broader context, and the specialists who take care of them are often vascular specialists in neurology, neurosurgery, some of which you'll meet today, and so we really want to bring our experts together for you today. So cavernous malformation, oh, my N fell off there. That's the one we're going to talk about. So part of this is like, what the heck are we talking about? A cavernous malformation. So the medical dictionary, they start with cavernoma, because at least that's a common term that you'll hear. And really, it is described as a vascular tumor of the brain, because that's what the Latin derivative is. And maybe that's an easy place to start. Like, what is this? But you'll hear the word cavernous hemangioma, a cavernoma, a cavernous angioma, a cavernous malformation of the brain, or CCM, which we'll spend a bit of time on, capillary hemangioma, and sometimes even the word occult or cryptic, because it doesn't show up when you do an angiogram and look for these things. So if we can't even figure out as a medical community what to call this, how challenging it is when someone is first diagnosed with something. And this is just, you put the word into Mr. Google and you get 10 million things. And so I think this is part of why I think it's difficult to navigate. And even as on the physician side, we have a lot of education to do of our peers and colleagues too. So I think that this is the first step. And I think most of the community organizations really favor the angioma version of cavernous angioma. We in the kind of research and clinical community, because we deal mainly with cerebral cavernous malformation, that's probably the next most common thing you'll hear. So I think if we sort of stick to at least a narrower nomenclature, that actually might help our teams come together a little bit easier. Okay, so if we can't figure out what it's called, we can at least begin with what it is. And I think when we describe these things using our best tools, using tissue diagnosis with our pathologists, our radiologists, it's really these abnormally enlarged capillary cavities. So what am I talking about here? Remember that in any blood vessel bed of the body, there's an artery. So that's typically drawn as red things. If we're going to color code, we are not color coded on the inside, but red is the arterial side. It's the side where arterial blood comes out of the heart and perfuses tissue. And then on the venous side, which is the blue side, it's the tissue now that all the oxygen and nutrients are extracted, comes out passively and back to the heart again. So if we just had arteries connected straight to veins, that's a different kind of problem. That's called a shunt, and there's high flow going from one side to the other. Well, nature's smarter than that. We actually have these smaller blood vessels in the middle that actually take that high pressure gradient and diffuse it out over smaller and smaller and smaller vessels so that on the other side, the pressure's lower. Those special vessels are called capillaries. And I think this is where we think the abnormality of cavernous malformation comes from. It's these capillary beds that are designed to form a special way of reducing pressure in the brain. And when those things get misconnected or are not well formed, we have abnormally large capillaries. And these are in places where there's no brain in between. So this is just really kind of a little spot of blood tissue. They're very thin-walled, and so they often form these kind of bubbles, and often described as raspberries or mulberries. And that's kind of, if you sort of think about it, if I have a capillary that is sort of malformed or a little bit bigger than it should be, and it's very thin-walled, it can stretch and form into these funny shapes. It's thought to have one layer of endothelium, which is basically the skin layer of a blood vessel. And the tissue at that point, it doesn't have the normal architecture anymore of what we separate the blood and the brain. And so this is thought to be very slow flowing, so not like an AVM, which is this kind of scary vascular malformation most of my patients think they have when they come to see me. And I can at least start with some good news that it's not a shunt. It's not this high pressure artery to vein shunting, a related but very different disease altogether. So I hope that at least gets us closer to all being on the same page of what it is. Okay. And then, well, who gets these? You know, obviously, all you folks in the room are here because you or someone you know has one. Prevalence is a number epidemiologists use to sort of talk about how common is this in a population. We're looking at 0.1 to 0.5% of the general population. That generally means very low. So it's a rare disease. And that makes you all very special, which is nice to be special, but sometimes we don't want to be so special all the time. And so it is rare. And there are kind of two flavors, what we call sporadic, or it just happens randomly in someone's development, or it's familial, well, there's actually multiple family members that are there. So about 20% of cases are familial of the already rare condition. When they're mostly what we call sporadic, they're often just singular lesions in one spot in the brain. And that's the most common, 80% type. But when we start to see multiple in different parts of the brain, we start to become very suspicious. This could be a familial or genetic form. And it's a little bit of a misnomer when we say CCM, because not all cerebral cavernous malformation, they're not all brain lesions. Some of them can be in the spine, they can be in the eye, they can be in the skin. So I think that this is a disease that affects blood vessels, like we said. These capillaries exist in all tissues of our body. So if you have one of these rare things with a particular genetic form, it may affect other tissues of the body too. And so I think it's just important to think about this as not beyond kind of a brain and disease in and of itself, although that's obviously the organ I think of the most and clearly the most important one in the body. Okay. All right, we're going to get into, hope you guys are already finished lunch a while ago. We're going to go a little pathology here. Okay, so what does it look like when you look at one of these under a microscope? It's really what we think of as these network of vascular spaces. You know, it's these capillaries that have enlarged. And so there's no brain in between, but you can see, even if you're not a trained pathologist, these little channels here are like holes in a sponge. And so that often is how people describe it, that these blood sponges. So these spongiform kind of areas that are there, and there's blood products in it. And so the areas where the blood is, where that arrow shows, that's what shows up when we take pictures. You know, because otherwise it looks like blood tissue, and you wouldn't necessarily see it because it's so small. But when there's blood products in it, then we can actually start to see it on pictures. So what does that look like in radiology? So this is an MRI scan, and we'll kind of talk a little bit about that. MRI scans are the most commonly used to diagnosis because it's really good at detecting blood of different ages. But MRI scans are not all made the same. So our radiologists are very advanced. They come up with new sequences all the time. And so we have to also keep up with what is the appropriate sequences. There are many patients who often maybe get an MRI, but it's not the best one for looking at this. And so we often have to have patients have an imaging study again to kind of make sure we have a better look at what these are. And so one of the things we try to do is have at least a common standard, no matter where a patient may fall in the medical system, they're at least getting the right sequences of MRI. They don't have to get all the fancy research ones, which there's a lot of really neat things in the research side, but at least to get the right basic standard, you know, imaging. And I think we're still falling short a little bit in some of our places. And so making sure that as folks who see patients with this more and more, we advise folks, especially with insurance constraints, like I have to get my MRI at a particular place, then at least to request the right MRI. So they're not wasting a person's time, energy, and ultimately the economics of it, because one MRI done well is certainly better than 5 MRIs done poorly. And so the MRI sequence that we use, besides the basic ones, so what we call a T2 and a T1 are the basic sequences. We also add one that's very, very sensitive to blood products, because as we talked about, it's those kind of islands of blood products that are the most classic for these and are the most easiest to see in pictures. So what does it look like? It looks like this black spot. So not very pretty looking in terms of detail and architecture, but often detects kind of where the blood product is, and it can be blood of all different ages, right? And so I think that's one of the challenges is it doesn't necessarily tell us timing and what happened. We have to have actual person tell us their clinical symptoms, but it lets the radiologist sort of help us know where these are. And as this sequence has gotten more developed over time, it's become exquisitely detailed, where someone may have only had 5, and then the imaging got so much better in 2 years, they go back and take their picture again, and all of a sudden they have 20. I'm like, what happened? Some of it isn't that they grew 15 more, it's that the imaging got so much better at picking up these blood spots. So I think we have to also think about this in that context too, is that technology is rapidly advancing, which is as good points and bad points. But if we don't kind of, really think about how to message that to patients, how much anxiety does that cause for you when you've been told all of a sudden you have either too numerous to count, what a horrible word to say to somebody. Right? What do you mean I have too many to count? Too many of what? Brain cells, sure, I'll take that. But I think this idea that quantifying these, using the super sensitive imaging is also going to make our radiologists work harder for us, and we should hold them to a standard of being able to kind of compare this in a way that makes sense. And perhaps moving into the automated field of really using more than just the human eye. Because you can see how, even with our new software technology, we can begin to think about even highly sensitive ways to use our imaging as a tool and helping patients think about that too. Okay. So this is sort of when someone comes in, sometimes when there's a bleed. A CT scan is actually really helpful for that because that'll tell you that the blood is relatively new. It's bright on a CT scan. So here it is on the MR, that dark spot, but on the CT scan, you see it shows up almost really bright, like the bone almost. And so, so oftentimes when someone has a symptom, they may go to an emergency room, and the first thing that someone will get is a CT scan. Doesn't have a lot of detail, but certainly can say, yep, that looks like a spot of blood. And that sometimes is really helpful to someone who's been having symptoms to know, did my cavernoma bleed? Because we're not very good at figuring that out. And it's all about timing because this CT scan may only stay positive for a short time. And so, often when patients are not having a lot of symptoms and you get an imaging study after the insurance and this, that, and the other, it's been weeks. And so perhaps that CT or MRI is missing the kind of timing of helping our clinicians sort things out. So I think these are kind of some of the caveats of our fancy imaging is that it's very sensitive, but it's also not great at timing. And we still need the patients and their doctors to be on the same team and working on efficiencies of when to order these things and how to order them so that we can, use our tools to their highest effect for you folks. All right, I'm going to move on again. And like I said, there'll be a question time after, but just to make sure we cover all our topics, symptoms. This is kind of a basic symptom slide because it's the one that's published and this is what's in the textbooks. The main thing, obviously, we all worry about is bleeding. Bleeding in the brain is bad. 15% of patients present with first-time bleed. And that's often because they get a CT scan in an acute phase, so right away. And then the follow-up scan would be an MRI. Other symptoms, though, and equally common, like half of the patients actually present with seizures. Seizures are really, really common. So you can imagine what are things that irritate the electrical system of the brain. Blood products. And so, the way the brain communicates normally is electrical signaling. It actually talks to each other using electrical signaling. Just the way the heart tells itself to beat, the brain tells the cells to talk to each other with electricity. And so when you have something like a blood spot in the way of that communication, it can cause kind of a circuit that just goes a little bit around. So it's a short circuit of sorts. And that's why seizures are really, really common in cavernoma patients, because often it's that little bit of blood that's there is enough to short circuit the brain if it's in a well-placed area. The other things are headaches. Headaches are all different kinds of headaches. Everyone has headaches. It's so common. Yet headaches in a cavernoma patient may be a really different challenge and often delays diagnosis. If someone has a migraine and cavernoma, they often don't get imaged for a while. And so I think these are some of the challenges of having common presentations of a rare condition. And then obviously the things when the cavernoma is in a very, very important part of the brain. If it affects vision, language, movement of the body, it really depends a lot on location. And as we can see, these are tiny in some areas, can be larger in a very, very high risk area. And so the size of the lesions, the location, those are really what matters. And imagine how hard it is for doctors, because there's no one thing I can teach them to say, well, yeah, if the patient comes in with this, they absolutely have a cavernoma, because it depends. And so even our best physicians miss this because they don't kind of, this cavernoma patient does not look the same person to person to person, even family to persons in the family. So there's so much variability, it creates quite a challenge on the clinical side. Hemorrhage, though, is the kind of most feared complication and the one we worry about the most in terms of patients. And the risk factors we know, and these are really, hard to tell because these are rare conditions again. Females, the size and the multiplicity of how many CCMs one has is associated with risk of bleeding in the brain. The spinal cord, even more high rent territory. So spinal cord hemorrhage is quite profound. But hemorrhage rates are low. And I think this is hard, right? You have a rare condition and we don't always recognize the bleeds. So the low numbers probably reflect cavernomas in very silent areas of the brain. But then you have hemorrhage rates that are very high if you have a cavernoma, let's say in the brainstem, where even a small amount of microbleeding can cause a lot of symptoms in the neighboring area. And so when we think about bleeding, obviously we talked about the big bad bleeds of an AVM, a high flow shunting vascular lesion. Yeah, cavernoma bleeds aren't that bad, thankfully. You know, the AVM bleeds are very, very bad. Cavernoma bleeds tend to be less so, but not always completely benign, because if it's a cavernoma bleed in a very, very delicate part of the brain, it can be quite devastating too. So I think trying to put these in context of these like sort of bigger, other familial type of things, I think it's important to think about, you know, what we do with a cavernoma that bleeds. Because some bleeds are really bad and others are not, and it really helps us sort of think about how aggressive to be with treatment and what to do. And you'll hear a lot more from our surgical specialists here today about treatment. But we'll talk a little bit in overview in terms of, you know, some of the treatment is really the symptoms. If you have bad headaches from your cavernoma, treating headaches in a way that makes the cavernoma easier to live with. If you have seizures from your cavernoma, treating your seizures well is often kind of the way people manage. And then when there's hemorrhage, we start to really think more aggressively about, is this something that surgery could help with? And obviously surgery is no small thing, especially when cavernomas are in very, very challenging locations in the brain. Sometimes we also treat for seizures that come directly from a cavernoma. And someone's having a lot of difficulty managing their seizures. There's a special kind of surgery for that too. But the risk of surgery, as you'll hear more about, a lot of it depends on location, how easy it is for a surgeon to navigate those areas. And unfortunately, as of now, we don't have good medical therapies. So really it's symptom management and surgical management, which leaves a lot of our cavernoma patients really at a loss for what to do. So important to work on this, because how wonderful would it be to have some kind of medication that could help. And I know Dr. Kim will be talking to us a little bit more about kind of the future and where to look for directions on where to go with this. I thought I'd really kind of talk about a patient, because maybe this will be a little bit more relative to what you guys may have experienced. So this is a patient case from one of my colleagues. It's a 19-year-old woman. She had syncopal event, which is a fainting spell. So some people faint, like even young people. And during that time, someone scanned her brain and she found that she had multiple of these. They weren't necessarily symptomatic per se. And she, as most 19-year-olds, was otherwise healthy and decided not to do anything about it, and it was not a big deal. Or maybe she didn't even know, or no one told her what these were. 2 years later, she's 21, and she gets a follow-up image, and there's a new lesion that's there. Finally, someone asked her her family history and says, I think my dad had a seizure and he took some medications, but it was so long ago, it was 30 years ago. He doesn't seem to have any symptoms now. You know, the MRI showed, again, multiple. And so I think, you know, obviously now we would say this is a patient who we would probably offer some genetic counseling to, thinking about a more robust family history. Are there more people in her family that could be affected? She's getting to an age where she's childbearing, and perhaps someone should counsel her about these things. And so I think, you know, it illustrated a lot of gaps in her care of sort of what happens when someone who is otherwise young and healthy sort of shows up in an emergency room and maybe doesn't have a neurologist, or perhaps he never got referred to one. And so I think this is something that we struggle with all the time in our healthcare system. This is her MRI scan. So this is what we call a T2 weighted MRI. So this is an MRI not specifically for blood products, but does show tissue really well. And you can see that she has multiple. And I don't have a print on here. Maybe I can use this. So there's one right there in the Mickey Mouse ears. Is it showing up? I don't know. Well, I'll tell you that she has one in this top one. If you really look, there's a little bright spot in the brainstem, which kind of looks like a little Mickey Mouse here. She has another one here, a little black spot on that one. This bigger one is obviously a little bit more prominent and present. So even back then, she had multiple. So fast forward, 23 years old now. Now she has a big headache and double vision. And guess what they did? They sent her home from the emergency room with an ocular migraine. And this is someone who, if someone had bothered to kind of look through her past medical history, maybe ask her what happened in the past, maybe she wouldn't have gotten sent home. Well, lucky for her that she didn't just stay home. She actually had more symptoms and came back into the hospital. And this time she has a new pontine lesion. And so the pons is kind of at the level of the eyes. You can see she's got this sort of bright lesion there. And this one is a very, very difficult area. You know, she's in a brainstem area where obviously all the symptoms are coming from that. But it's a hard area to operate in. And I'll defer to my surgical colleague about sort of some of the challenges of brainstem location. So at this time, you know, there's a lot of discussion about what do you do? Do we go in now and try to operate on this? She's still so young, but she now has some symptoms that are concerning. This is something that'll get better with time. If we let some of the swelling go away, what do we do? And this is often a controversial area for sure. So I think initially the thought was, you know, let's just see how this goes and perhaps this won't cause any more trouble, let it subside. Unfortunately for her, she bled again. And this time, much more severe, and the CT did show acute blood. And at this point, she did go to get the surgical resection. Luckily, you know, with a very, very skilled surgeon, she was able to recover from this, but does have some residual weakness, you know, and I think that this is something that we always have to balance, the risk of the intervention, the risk of bleeding again. These are all really, really difficult things for our surgical team. And I know we're going to hear some really amazing things in terms of the surgical arena in our next talk. So I'll save some of that for our next speaker. But it does tell you, you know, what do we make of these familial CCMs? These are really different than the solitary single lesion that may have quite a benign course, and perhaps folks are going to be okay without much of anything. But these 20% that are really, really difficult, what are we going to do? Oftentimes, you know, if it's on one side of the brain, some of the risk factors are exposure to radiation, some of the environmental things. But when we see multiple of these in different parts of the brain, it really does raise our index of suspicion for a familial cause. And we know that even within a family, their presentations can be wildly different. But we have an amazing story here with CCM. And if you think about the genetics of it, we have 3 known mutations. 1995, the first one discovered. And these are courtesy of Dr. Kim, who's going to tell you more of what's going on with this. But, you know, we found these 3 mutations, and they're not all identical or the same. But you can kind of see the progression of the discovery as we really figure this out. Another way to look at it is this kind of bar graph. So we said 20% are familial, the CCM1 mutation, also known as CRIT1, CCM2 mutation, less common, CCM3 mutation, and new ones that are still kind of not named, but certainly on the horizon. And then I think one of the things to illustrate, you know, this is a CCM1 family. And we have a 51-year-old with 2 lesions, a 53-year-old with 603 lesions with epilepsy, a 56-year-old with 713 lesions, some mixture of small and large. This is one mutation in the same family, yet how wildly different. And it wasn't an age thing, they're all the same age. So we're still really trying to grasp what this is. And the disease severity is really something that's quite challenging for families who have this. So this is sort of one example of that. And we know a lot about this CCM because the CCM1 is related to an ancestry that is really one of the most amazing stories in medical genetics. So this common Hispanic mutation was thought to be founded in the Southwest. This is, you know, really a time when a common ancestor from Spain in the 1600s probably came over to the New World, and really in this pathway along up to sort of the New Mexico area, we can see evidence of this genetic mutation in all of that. along this kind of interesting route of travel. So all the ancestors and generations. The Angioma lines has really been, big supporter of these sort of genetic studies. And one of the interesting things we see is the family historical piece in New Mexico. So this is a family that has this founding mutation, 1600. They can trace back to this Captain Cristobal Vaca. Amazing. That's where the gene came from, and the ancestry with this huge family that's affected. And so, their family came to New Mexico for a new colony that was a Spanish colony, and it is one of the largest CCM families ever studied. And so part of studying these really extreme kind of mutations and families like this, it tells us a lot about a disease we don't know very much about, and to begin to understand why people get this in the first place. And I think it's an incredible lesson from genetics that you'll hear more about. And so what are some of the lessons? We know that the number of lesions may be very important in familial CCM and how severe the disease is. The total number and how many large versus small, you can inherit that. There may be some things about how our immune system responds to things. So maybe it's not just the gene mutation itself, it's sort of how it primes our immune system to react to this. And that can really modify things. And then I think there's some real interesting things about how our environment, our GI tract, our diet, these things are part of sort of the new kind of cutting edge stuff that is quite amazing in familial CCM. I'm going to end here a little bit with just some frequently asked questions about sort of, what we do in this area here. So, this is sort of a bit of a highlight, a journey through all of this, but I feel like we need to kind of bring back to kind of some of the common things we get asked. So what about pregnancy? What do we do if me or a family member has this? We actually don't think that, based on information and data, and granted it's limited and in rare conditions, that the symptoms in a pregnant versus non-pregnant state from the CCM are probably not that different. The caveat being, if you have seizures, you have to sort of modify your seizure medication during pregnancy, or if you have migraines and headaches, you might have to change your medications. But the CCM itself doesn't seem to be altered by pregnancy versus non-pregnant. I certainly allow all of my wonderful female patients to have kids, to have the kind of birth and delivery they want, and not have OBs scare them about anything otherwise. But it's a team. We really should make sure that we're advising our obstetricians very well of this condition too. Familial cases probably should have genetic counseling when they're childbearing and what to do about it. The big question, which I wish I had a really yes or no answer for, is can I take blood thinners? It's like, well, depends. If I'm taking ibuprofen every day just because it seems to work for my arthritis, that's a little challenging versus, is there alternatives? Are there other things you can take? We know that if patients need a blood thinner because they're having a heart attack, they're having a stroke, they have received the most potent of blood thinners, even with their CCM diagnosis. And the safety factors seem to be not that much different. There is a little bit higher risk, but it's not prohibitive. So I do think if you're going to have a massive stroke and we have a CCM, we have to be really careful. But I wouldn't necessarily withhold a life-saving therapy from a CCM patient, because I don't think that's doing the right thing for our folks. I think a CCM patient who bleeds a lot, we might have pause. So I think there are different individual reasons not to do that. But I think in general, when I hear these stereotypes about CCM patients, we really need to be a little bit mindful and think about the individual person too. What about, limiting my activity? If I exercise, if I do things, is it going to make my CCMs bleed or get worse or grow? There's really no information that would suggest extremes of exercise are bad for you. In fact, I think exercise is probably good for you and all the good reasons for it. So there's no reason to change physical activity, but we do have some restrictions on seizure patients. Seizure patients, depending on how well they're controlled, they probably shouldn't be doing high-risk activities like climbing on rocks and things like that if they have seizures. So it's really the risk of the symptom more than the CCM itself. So we usually have isolated risks for the kind of symptoms the CCM causes, not because you have them. I actually encourage people to live healthy lifestyles no matter what. And so I think it's just important to put that into context. So I think to wrap up here, what are our goals? What do we want to do? We want to understand what's the risk factor for hemorrhage. We want to understand what it is, why in some of these families, size and number matter. What is that something we can modify? Is that a target for a future treatment? People who bleed once, what's the risk of bleeding again? I mean, that's the unknown question that a lot of CCM patients have to reconcile with. And, what's almost worse than knowing this is the unknown, like fearing the next time this happens. And there's not amount of reassurance and words I can give to someone who's been through this to say, the anxiety that comes with worrying and wondering, if not for yourself, for your loved one. And so I think these are real, and we have to appreciate the kind of support, even though we don't have all the answers, to still be supportive. I'm okay with patients calling me and saying, I'm having a bad day. I need to just hear that I'm okay. And that's important. That therapy alone, I can't cure you, I can't make this go away, I don't have a magic pill. But I think to acknowledge that people are scared and that they need to have somebody to turn to who can at least provide some rationalization, even if your brain is sort of telling you, I know I shouldn't worry so much, but I do, right? And then I think that, the future is real. Like, we have amazing research that, our colleagues around the country have banded together to study a rare disease, to try to think about genetics, family risk. How does that apply to someone who doesn't have the familial form? What is it about genes and environment that we can do? I think that the future is pretty bright in terms of the work that's being done, but it takes a while. And so in the meantime, I think to stay engaged as a community, to really be supportive of each other, to really kind of, be aligned with places that can give you the information so you feel empowered with a disease that sometimes takes your power away. And so I think these are some of the messages that we want to make sure as a community of physicians and patients and caregivers, we are on the same team together for this. And then I think lastly, we cannot do these by ourselves. The CCM team at UCSF is big by intention. Dr. Smith and I run the neurovascular neurology group. We have several physicians that are qualified to do this, but because it's a rare disease, we want to try to at least make it easy to navigate and find us. Our surgeon, Dr. Abla, is trained to do surgery in this if surgery is needed. We have an epileptologist, Tina Shee, who takes care of all of these patients with her epilepsy team. A medical geneticist that can really help counsel when patients do have a familial or suspected familial group. We don't always test everyone because the implication of testing is real for insurance reasons and things like that. But you need to know that. You need to know if you're going to get tested and where to get the high quality tests. And then our radiologists working on really cutting edge things. Fortunately, these don't involve a lot of invasive testing. We don't do a lot of angiograms in people because it's a cult. We don't see it on an angiogram. So anyone who wants to do angiograms on a known CCM patient, walk away. It's not the right thing to do. And then because it's a familial disease, we have a pediatric team that really can begin to think about the young ones in the family, because they may need a different style of care from a pediatric neurologist. They have a different approach to kids and families that I think is much needed, including a pediatric neurosurgeon. And then, of course, my partner in crime, Dr. Kim, who is really doing incredible work. And so I'm excited for you to hear about some of the things this afternoon about where we're going with this. So please don't hesitate to contact us. The phone number's there, gets you to our clinics. And we'd love to really help more because, we have to sort of band together when things are not common and really think about how we can help people the best. So thank you for your attention. I'll be around in the afternoon as well.
We have some time for questions if anybody wants to.
Sure, yes.
What's the mutation name for the sporadic version? Is it also called CCM1, like the familial version?
Yeah, no, and so these genetic disorders, and I will defer to our genetic epidemiologist, the familial ones are really, they were found in the family. So they are familial gene mutations, but you're right, there are sporadic mutations in the same area that are often found not in families too. So I think that's the challenge with these. We found some of the original genes in these large family sets, but they're always finding new things in patients. So it's hard to find a novel genetic mutation in general, but there are some sporadic cases that have been looked at. but I don't think they have sort of this known familial gene that has a pathway attached to it. A lot of research has gone into understanding that CRIT1 mutation with animal models and human models. But I think the sporadic genes are definitely ones where this is now where we can do genetic studies so easily on people. We're finding more and more things that may be related. Not quite sure what to do with all of the genetic mutations because we don't know what the gene does. But you're right, the sporadic population has been associated with some of these sort of new mutations that aren't necessarily in families. But CRIT1 is really a familial one.
Can you just clarify somatic mutation versus?
Maybe I can take that.
Okay.
So sporadic CTMs, so these lesions, the difference between genetic or familial forms is that it's present, the mutation is present in every cell of your body, including the ones that you would pass on to the next generation. So a somatic mutation would occur after development. So in a single cell that then divides into daughter cells later, but it's not in your germline cells. So they have identified in tissue mutations in either one of these CCM1, 2, or 3 genes and in sporadic cases. And that explains kind of the same pathogenesis that's involved in sporadic disease as in a familial disease. But the distinction is the ability to pass on the gene mutation to the next generation. So that's kind of the major distinction between sporadic and familial.
Yeah, go ahead.
I'm a strange case because I'm one of these people with DBA, and I have one that's about a centimeter, but they found a second one.
Right.
And I did have the genetic testing, and it shows sporadic. But could I have a as yet undisclosed, undiscovered gene? You know?
Yeah, no, good question. I think, I didn't touch on this associated DBA or developmental venous anomaly. It's a vein that drains normal brain tissue next to a CCM. And, many patients, at least in the community of physicians, we sometimes think of a DBA with a CCM as an anatomic picture of what's a sporadic, because the familial ones tend to not have them. I don't think there's any nevers and absolutes in science. So I think that now that we are starting to see more and more of these, I think you're right. We can't say that just because you have a DBA, absolutely you must have no genetic familial form, because I don't think that's absolutely true.
Or that you only have one.
Exactly. So I think that, we're still in the early phases here of understanding these more. So I think the way that we traditionally think about genetic diseases are the familial kind, the autosomal dominant, you hand it down from generation to generation to generation. As it works out that, you can have gene disorders that happen anywhere along the developmental course, and even after something is, so sort of, this is how cancer genes mutate and you form cancer. So I think we're learning that genetic mutations can happen even later in life, and maybe a different version of the traditional familial genetics. I'm not as eloquent as Dr. Kim in describing all the versions of genetic disorders, but I think this is part of our understanding of, what is the future here, that perhaps everything is actually genetic in some way, shape, or form. We just don't have the tools to really understand and look at them, and those are getting better.
My actual question was hormones, actually.
Yeah,
She just happened to mention the sporadic. Any new research on hormones?
It's there's no nothing definitive in terms of just are hormones bad or good for CCM. We know in some areas of brain vasculature that there's been association with hormone use, but not specifically the CCM. So we don't know, and I'm sure you guys hear that a lot. There's a lot we don't know, but I think it's a pathway that certainly is important to look at when you're looking at. The more we understand these known mutations and how they affect the tissue, then I think it's easier to see if hormones sort of could influence the environment around some of these genetic disorders too. And that's kind of where we're working on the gene environment interactions. What is it about someone who has this? That alone doesn't always lead to a CCM. It's that plus something else that happens in the lifetime that really makes a CCM form. I think these sort of two-hit phenomenon are more common in disease than anything else. Yeah.
Dr. Cohen, do you have a counterpart or a CCM clinical team at UCLA? We know about
My mother's.
Oh, wow, I came a long way.
Not a lot of resources.
Yeah, there's certainly wonderful neurologists and neurosurgeons at UCLA, certainly colleagues that do that. I don't know if they're organized in a particular way. I would say if you are gonna go to neurology at UCLA, probably at least try to start your journey with a vascular trained neurologist. That's often somebody who has the most knowledge about this. But you're right, I think not every place has it. I think this is what the Angioma Alliance is trying to do, is sort of create expertise so folks can come close by. We do see people from Los Angeles, absolutely, but I know it's not easy. It's not easy. Okay.
Just a comment from one of our webinar attendees. As Dr. Ko noted, this disease impacts the family and patients so much. To add mental health, neuropsych involvement is so helpful in the journey of CCM for familial families. So more of a comment.
Absolutely, and I think this is even more important when kids are involved. So I think our pediatric group really does that even better than the adults do, and I think we can learn a lot from our pediatric colleagues. They're very much interested in development and mental health issues. I don't want to keep us off track. We're actually being really good at staying on schedule.
Okay, our next speaker is from Stanford University, and his name is Dr. Kumar Abhinav. He is a cerebrovascular neurosurgery fellow working under Dr. Gary Steinberg. Dr. Steinberg wished that he could be here today, but he's out of town. However, I think he probably would be feeling that he's got a very good representative, great representative here. And Dr. Abhinav is going to be talking about specifically, I'm not going to say your thunder, but a lot of this is going to be about CO2 laser neurosurgery, which is relatively new. It's something I'm not very familiar with, and I'm really looking forward to hearing more from Dr. Abhinav. Trying to step up. There it goes. Okay. All right. You're up. Oops.
Oh, thank you. Stand by, everybody. If you want to grab a snack, go for it. I'm just going to go. Yeah.
While we're doing a little reboot here, I was just asked to take a little poll and also to find out who's in the room. So how many folks here have the genetic familial form of the illness? Or have a family member who does? Okay. And how many here have the somatic mutation, the sporadic form, where there's only one family member affected? And then my other question always is, how many folks here have brainstem involvement? Because I think that gets overrepresented in our meetings usually compared to how many there are in the population of people with CCM. And how many people struggle with seizure as a result of having their lesions? seizure folks didn't make it today. Just this is for the webinar people who are watching. We have one seizure folks, but we have a number of different folks with brainstem, a number of folks that have a hereditary. Do you guys feel comfortable doing a round of at least first names, just and maybe the town that you're from? I don't want to do last names just because we are doing this as a broadcast that's going to be on YouTube later. But if you don't mind doing just your first name and telling me what town you're from, that would be great.
Dava Sanamone
Okay, and Libby was here.
from,
I'm here.
Okay.
I'm always late. Libby Buddy. I'm from the Bay Area.
Yeah.
Oh, all over. Danville, Tracy, Shannon.
Melly from Campbell.
We're here for Eli, who's in LA.
That's right, yeah.
Alex, I'm representing Eli.
oh, sweet.
And Eli is a child. How old is Eli now?
4.5.
He's 4.5. I know you guys.
The rest of us don't.
I don't, there's two of our speakers and the other one's my daughter, Julia. Okay. Your son?
Michael.
Michelle from the Bay Area. Hi, good to meet you.
Denise and Patrick from Dublin. My daughter Chloe 3. And she had a year ago with Patrick.
Good to see you. Good to have you here.
Elizabeth, very good city. Here.
And Yvonne was sitting next to you and she just stepped up for a minute. Isaac?
Isaac, our son, Luke, 20, brainstem, Cavernous, Malformation.
I'm Morgan. And Luke isn't here. It's just the whole rest of the family that's here. Yes.
I'm Mike from Los Angeles. I'm Mike for the Rich. From Los Angeles.
And
For my mother.
That's for your mom? Yes.
Tim from San Francisco, my wife Jamie.
Jamie, and Jamie, you're the one who's a captain. Yeah. In the back.
Talia from Sacramento.
Melissa from Sacramento.
Do I know you guys? All right. Do I know you guys already?
Yeah.
No, okay.
Connie, I'm from San Jose. I'm here for my mom. She's in Cleveland.
Thanks for coming.
I'm Josh from Saratoga and 7 years STEMI.
Wow. Thanks for coming. Dr. Hetz is back there in the corner from UCSF.
Megan from Santa Cruz.
Good to meet you. Oh, we know who you are. Megan from Santa Cruz. Okay.
Lisa from San Francisco.
Good to see you.
Alicia from Hayward.
Good to see you too. And I think we are now ready to get
Great.
going.
Thank you very much for the invitation. As we've already apologized on behalf of Dr. Steinberg, I'll repeat that. He's very sorry not to be here today. So my name is Kumar, and I'm his current cerebrovascular fellow. I've been part of these few of these cases, obviously not all of them. And thank you, Dr. Ko, for a tremendous introduction to the condition. So basically, the focus of the talk today, from our point of view, is talking about the deeper cavernous malformations, which are technically more challenging because any part of the brain is really eloquent. However, when the cavernous malformation is deeper in areas we talked about, was Dr. Ko mentioned, like a brainstem, thalamus, which is another part of the brain, which is like the relay center in your brain, and also the basal ganglia, which really modulates your movement and controls your speech and various other functions. Then there's a greater degree of anxiety associated with both when it hemorrhages, what sort of symptoms you might get, and also when you have to try and take it out, because there's technically the brain is highly eloquent around it. So certainly in his old series, which is the Pandey et al. I can't point here, but from 2012, we found retrospectively looking at the data that the bleed rate per year for these deeper malformations was about 5.1% per year, with a rebleed rate of 31.5%. So these are not lesions that are totally harmless. They do cause a lot of deficit, a lot of problems. And yet at the same time, you have to really balance out the risk before you consider or you embark upon surgical resection. A little word about radiosurgery. Slightly controversial whether you use radiation treatment for deep-seated or surgically inaccessible cavernous malformations. There are groups who believe in it, particularly Pittsburgh group, for example, have radiated a lot of cavernous malformations, and there's a paper that I have reference for on the next slide. Dr. Steinberg's personal philosophy on the whole is that radiosurgery doesn't work for these type of malformations. And certainly all the ones that he has excised following radiosurgery, we've almost always have evidence of some of the cavernal which is still active, hasn't completely thrombosed or completely clotted off. And then the other issue is also necrosis, which is the adverse effect from the radiation can cause swelling in parts of the brain and cause problems for the patients. So these are the different series that have been published regarding radiosurgery. Like I said, the big series from Pittsburgh, where Dr. Lunsford is, they say when you treat them with radiosurgery, the risk, after about 2 years, so it does go down for these patients. But it is not our sort of practice, basically. So today, when I talk about the series, I know in the book, I think I said 283 or something like that, but we'll talk about the 286 patients with these deep cavernous malformations, and also I'll refer to some of the results that were published with respect to a smaller cohorts earlier on in neurosurgery, and talk about some of the challenges and what we found across this patient group. So as you can see, almost 60% of patients in this group had multiple hemorrhages. So again, our threshold for operating on deeper ones, you really want to see if it's absolutely necessary before you try and take out a deep cavernous malformation. So this was the paper published in 2013, I think, and we had 176 patients at the time. And really the take-home message from the paper was that the cavernous malformations that are located, that are in these development parts, can be taken out. Most patients, in terms of when one is asked the questions, who are the patients that are going to do well? If you are well at baseline, so your performance status is good, you're able to walk, you're able to do most things, the likelihood is that that performance status will be maintained over long-term follow-up. So when the patients wake up, we do tell the patients and the relatives that there is a good likelihood that you may wake up with some issues like weakness, problems with eye movements. However, over the follow-up, majority of the patients either go back to being no worse or being better, and I'll show you more sort of specific data. And if the performance status is poor at the baseline, by that I mean patients have an extensive disability and they've had multiple hemorrhages, then that outcome tends to be poorer over the long-term follow-up. So as you can see, majority of the patients who have these deep-seated cavernomas present with issues like, so bicranial nerve deficit typically tends to be problems with eye movement, double vision, can have facial weakness. Motor deficits is, again, we're talking about weakness, usually on one side of the body, either it can be as bad as complete or severe weakness or mild weakness. And it's also sensory symptoms, so that's mainly things like numbness, sometimes quite a lot of pain in the extremity. And patients can have balance issues, particularly with cavernous malformations that are located in the brainstem. You can have issues when you're walking, you feel very unsteady. And in this slide, when we talk about the MRS is like a grading scale, which assesses your level of functioning. It's a subjective scale. It can have issues when different people are rating you. But in effect, we tend to call people who have MRS less than 2 as a good performance status, meaning thereby they're either independent or they only have slight disability. So the outcomes in many papers often get stratified as either good outcome, which is less than equal to 2 or greater than 2. And as you go up on that scale, the disability or the extent of disability essentially goes up. So in this initial paper, almost more than a third of the patients had poor performance status as defined by that scale at baseline. In terms of location, again, Dr. Ko referred earlier on to pons, so it's one of the parts of the brainstem where large majority of these malformations tend to be when we're talking about deep-seated malformations, part of the brainstem. And the other areas include midbrain, which is also part of the brainstem, slightly higher up. medulla, which is the lower part of the brainstem, and the other areas that we mentioned, basal ganglia and thalamus. In terms of personal preference, or at least what his preference is, he tends to or likes to operate once you've had a hemorrhage within 4 to 8 weeks since the last hemorrhage. And the rationale for this is really that when you have the blood products around these lesions, around the cavernomas, often there is a plane there, that you can go down and take it out. And a hypothesis, or rather the thinking, is that that plane therefore allows less injury to the normal brain around these lesions. So our preference is to try and operate within 7 to 8 weeks or 8 weeks. Obviously, at the same time, we are mindful that the patient should have recovered, should have made some recovery, because you don't want to go in when patients are. So those are the kind of factors we take into account. There are lots of adjuncts you use when you're operating. Patients tend to be unconscious most of the time under general anesthetic. There are times these surgeries can be done awake, and I will show you an example of that. So when we are operating and the patients are asleep, for example, when you're operating on a brainstem cavernous malformation, you want as much information as you can in that state to make the surgery safer. And one of those ways is to use what we call neuromonitoring. So we are really checking your different pathways in the brain, which supply your strength, which deal with your sensation, with your vision, and we have a neurophysiologist at hand who tells us that, look, whatever you're doing is potentially making things worse. So at that stage, we either change our approach or our trajectory or how we are getting to the lump. But these are some of the adjuncts that are extremely important in minimizing that mobility from operating in a critical part. One of the other things is obviously navigation. It's much like the GPS in the car. So when you have deeper located lesions, we want to make the smallest possible hole in the brain, try and get down to the abnormality. And in that sense, this sort of navigation system, or like the GPS of the brain, is extremely useful. In order to get there, this is where perhaps the experience of a center or people who are doing lots of these comes in. There are so many different ways of getting to an abnormality that's located in the brainstem or in one of the, and that's where the surgeon's experience. The basic fundamental paradigm is that we want to get to a lump or an abnormality while distorting the least amount of normal brain, so, and that therefore gives you have 3 or 4 choices of getting there. Either you can go from the front or the back, but at all times, what we are looking at using T1 images, which Dr. Ko referred to earlier, is how close is this lump to the surface. So the closer the cavernoma is to the surface, technically, the less risky it is, because there you can get to it without potentially going through normal parts of the brain. But sometimes you don't always have that choice. In that case, you try and take the shortest trajectory, the shortest path through the least amount of eloquent tissue. So these are the different sort of competing factors that you have to take into account. And what this slide is showing is that to get there, we have to take off bone, different parts of the skull. So it's better to take off more bone so that we touch as little of the brain as possible, because the bony bits we can repair at the end, but it's the brain that we're trying to protect. And that's what those arrows are really showing. So for example, if you have a cavernous malformation in medulla, which is the lower part of your brainstem, extremely critical for multiple functions. The most common route, I don't have a pointer, but you see the black space, the fluid-filled space, that's called your fourth ventricle. And most commonly, for this sort of operations, the patients are lying prone, which is head down, and we normally make a cut at the back of the head, a straight cut, and tend to go from the back through the cerebellum, by taking the cerebellum to one side. So cerebellum is that structure at the back which controls your coordination and various other functions like that. And the idea then is that if it's very close to the surface, you can see the black space, that's fourth ventricle. The idea is that if it's very close to the surface there, we can make a small cut and deliver the whole thing out through that small cut. So this lady, for example, you can see the hole in her medulla, which is the part of the brain stem. And she made it, she actually did really well, but then she had a phenomenon called Onlin's curse. Have anyone heard that? Or, no? It's really a phenomenon whereby when you're awake, you can breathe absolutely fine, but when you go to sleep, you kind of forget to breathe.
Mm.
So, it's that's why the name occurs. And she fortunately actually recovered her ability to breathe over 7 weeks, but there are patients who don't recover, in which case it's very problematic. And the other part of the brain is brainstem is pons when we go slightly higher up. And again, this slide, this really just showing you there are so many different ways of getting there. And sometimes that's why an experience, when you're doing lots of these, when you have cumulative experience comes in to choose that best route. And many times we have to involve people from other specialties like the otolaryngologist to come and do some of the bony drilling in order to get to where we need to. So I'll show you an example. So the bulky part you see at the front, this is your pons, this is known as your pons, and you can see the cavernous malformation right there at the lower part of the pons. And in this case, we went from the back because you can see on the scan on the right-hand side that it's pointing a little bit more towards the left side. So we went from the left side, and what you see, let's see if the video plays. Okay, anyhow, so what you're seeing here is that the white structure that you see lots of blood vessels there. The retractor, the metallic bit, is really pulling your cerebellum, which is the structure that I mentioned out of the way, and you're looking at the brainstem there. And you find this very narrow corridor to go down there and try and take the malformation out. Some reason doesn't play. Okay. So one of the things that we've been amazed by that we see when you look at these malformations, they seem to take up so much of the brainstem, but yet when you scan the patients post-operatively, you can see on the top right, so much of that space then gets filled by the normal brainstem. And in this girl, for example, generally, as I said, what you notice is that there is improvement over a period of time. But in her case, she had very rapid improvement in her weakness. And you can see the eye deviation on the left side, and that's really due to the sixth nerve, which is one of the nerves that supplies your eye. The ability to move eyes is still affected as a result of the malformation. So the reason I brought this scan up is that you don't always operate on these for obvious reasons that we talked about the risk and the morbidity. So for example, this is a 40-year-old male who's got a history of migraine and headache. The key issue here is that you can see the malformation, but it's too deep. You can see there's tons of normal parenchyma or the normal brainstem around it. So it's not really presenting to any one particular surface where we can go down and say, so that makes you nervous, and you say, okay, well, let's see what happens. We'll wait and watch. Because the morbidity, we're trying to take this out, is probably higher than the natural history, leaving it well alone. So then this person represents again and now has had 2 further hemorrhages, has got right-sided face weakness, body numbness, has also got double vision. So at that stage, you see it's still not quite coming close to the surface, but you make a decision, okay, it's closer, the person has had 2 hemorrhages, they may have further hemorrhaging issues as a result. So you make a decision to go in. And again, this is using this navigation system that I'm talking about. You identify your target, and you make the shortest possible plan using a trajectory and operative imaging to get there. In this case, generally what we do is your temporal lobe sits right here, and we have the patients, again, with the head turned, and we lift the temporal lobe up, and we go down to the malformation. So we do not go through any normal brain. So again, you're creating that corridor, which is least disruptive. So it's a shame this the video doesn't play, but let's see. Anyway, so what I wanted to demonstrate, so again, you see this retractor here. So this is pulling the temporal lobe up, which is part of an important part of the brain, particularly on one side, you can serve as speech, language, and function. And you're looking at the brainstem here. These are the blood vessels. And this is a structure we call tentorium. So the idea is then by cutting a little bit of that, which again is not part of your brain, we make a small hole and find the abnormality and take it out. So you can see this guy. So it's interesting. In this patient, for example, using the monitoring we had, the patient, what we were being told is that his motor strength is likely to be affected. He's likely to wake up very weak, which is exactly what happened. He woke up almost with no movement on the left side, but over a period of time, over a week or so, it got better. Now here is a case, for example, a 30-year-old female who has no symptom. So there is a case for leaving them well alone. So in this case, we didn't treat the patient. We said it's asymptomatic at this stage. Even though it's coming, you can see in comparison to the other ones I've shown you, it's closer to the surface. On the right-hand side, you can see where the brainstem is, and it's much closer. But if the patient is asymptomatic, you can elect, after discussing with the patient, that it may well be best to just leave this alone.
How did you find that? How did you discover she had that? How did you discover it?
Yeah, that's a good point. You know, a lot of patients get scanned. So I'm from England, so you know, MRIs are tight in England in terms of who gets it or not. A lot of patients get scanned for headaches, incidental headaches, migraine, and then we pick up tons of incidental abnormalities like Cavernous. In her case, it's a good thing that it was picked up because obviously, you know, there's a risk of getting hemorrhage from it. But we see a large number of patients where it's been picked up for a completely unrelated reason. So they may have had sinus issues, and they get a head scan and we picked up cavernous malformations. So as again going further up the brainstem, again there's another area called midbrain, and to get to this area, for example, you can see this is a 44-year-old female who had 3 previous hemorrhages and presented with left-sided facial and body numbness, also some speech disturbance. Again, this one, given the complexity of these lesions, is slightly easier to take out. You can see it's coming right to the surface. So we go from the back, again creating a corridor. So in this case, the patient is lying face down, and this is so-called cerebellum, which we are pulling down. And this is the back of the brain stem. So again, we have not transgressed to any brain. And we select the site exactly where to make that incision based on the navigation, and make a small incision and take the Cavernous out. Because the videos aren't playing, I can't really show you actually I have videos of making incision, etc. It really is a couple of 3 or 4 millimeters what we do. And again, to get to that part of the brain, you see this lesion. So this is in a similar part of the brain, but it's slightly further forward. But the fact that now it's further forward completely changes our approach, because if we go from the back, we have all that normal brainstem to go through. So this time we would go from the front and in between various nerves and blood vessels and try and get to the malformation. So that is where the judgment and the decision making and the experience comes in, to try and choose the route that is going to be least disruptive. And that's a post-op scan where you can see the lump is out. Sometimes you don't have an option whereby the vast majority of the brainstem ones, we tend to go from the back as a rule, you know. But there are times where, as we showed you in the previous scan, we've gone from the front or even from top of the head, like this chap who was a 31-year-old who had bilateral third nerve. So a bilateral third nerve can give you the ability to not open your eyes as a result of the malfunction of this cranial nerve. And in this guy, again, using similar sort of principle, how to get there, we see that the lump is closest to this fluid-filled space, which is up there, which is called the third ventricle. So we are moving up the brain. And so we went from the top, you know, we made an incision here, and cut right at the top here, and then we worked our way down like that to take this out. And again, over a period of time, that's Dr. Steinberg and the patient, gradually over a period of time, 14 months or so, his left eye started opening up. So as we're going up, you go from the brainstem. Another part of the brain is thalamus, and this is another very critical part of the brain that serves multiple functions. And for this, as the lesion of the lump is higher, our approach also becomes higher. So for these cases, we typically, again, tend to go from the back. And here's a 37-year-old male who had previous gamma knife radiotherapy, had right numbness and weakness. So he was doing fine, and then he had another hemorrhage. And this hemorrhage sort of left him with right-sided weakness, double vision, with his eye movement. So in this case, again, the idea was to develop this, just gives you an example of very narrow corridors that you work through, where this is part of the brain that serves your vision, which is to one side, and this is the midline, this is the middle of your skull, and we make that tiny little opening and work down that opening to where the malformation is. So one of the things is basal ganglia. So this is again part of the brain that serves it's like a relay, you know, it modulates everything. So when you're picking things up, it's a critical part of the brain that really controls everything from our speech to walking. And in this gentleman, for example, this is 20-year-old female, had 3-month increasing history of headaches, had some blackouts, and you see this malformation, which is located in the basal ganglia. The key thing here is that this is on the left side, and the left side is where your speech centers are. So these are the cases of patients where we would consider doing patients awake, and we would have a chat about them, whether you can have this operation while you're awake, and we can test your language function. Because in order to get there, you have to make an opening. So this is called, it's a naturally occurring fissure in our brain called the Sylvian fissure. And really, we open up the layers around that. But while we're opening it, we have to retract or pull apart parts of the brain. And even that gentle retraction can cause speech issues. So we'll have a discussion with the patients in the clinic whether they will be open to having it done awake. And if they can have it awake, we give them language tasks and test their ability to name things, read things. And if any of that is abnormal, we change our path, we change our strategy. So again, I had a video here where we showed this gentleman, for example, while taking out a malformation in that part of the brain, some objects as well as writing, and his speech got affected as we were taking it out, which was an indication to us that we need to change our approach. And afterwards, his speech was absolutely fine. So awake operation, when we do it, is very much based on the patient. We have to have that discussion up front. So some people just can't do it. They don't like the idea of it. And it's done in conjunction with people from the speech department, and we design tasks that are helpful in telling us, are we doing anything wrong? So about the CO2 laser, because the videos I haven't played, when we are taking out these abnormalities, we use something called bipolar. So bipolar is like, essentially you have 2 leads going down, and if our opening is about 4 to 5 millimeters in your brainstem, bipolar is probably about half of that, at least in terms of so we have bipolar in one hand and we have suction to keep the blood out. The advantage of the laser is that you can see it's a uniprobe, it's a single probe, and what it allows us to do is gives us more space to work, because you have a single tip, a single probe, and we don't have to switch instruments. So with this one probe, we can cut like any other standard laser. We can also coagulate. By coagulate, I mean you're just stopping the blood supply, so you're sealing anything that's bleeding. So with one probe, we can cut, we can seal the areas that are bleeding, and it also allows us, it gives us more space to work in, because it's less cumbersome, it's less big, it's smaller. And the disadvantage of using this is that for bigger blood vessels, it doesn't work so well. So even though we use this, we have to switch back to the traditional stuff in between using the laser. And really, one place it's been extremely useful is the brainstem, where the cut that we make is 3 to 4 millimeters, and having just 2 instruments with one single tip and another small suction has been very, very useful in taking these out. So this was an example of a video. So here is another malformation. You can see this is at the back of the area that's called midbrain pond. So we went from the back again, and you can see, although the video won't play, you can see that's the laser, the CO2 laser, which is with which we can even make the opening. So you can see how it's a very small profile instrument, and we found it extremely useful. And when we actually also send the tissue around this malformation for examination, using traditional technique and using the laser, we found that there was less injury to the normal brain and the tissue around it in comparison to just using the laser. So that's just summarizing what I said. The main disadvantage, as I say, sometimes around the corners it can be tricky, and also when it's bigger blood vessels that are bleeding, we often have to switch our instruments. So in the latest series that we have, looking at some of the numbers, so now he has probably about over 28 years, he has about 286 patients that he's operated on with these deep-seated malformations. And this takes me to the point that I was saying, when you look at the patients in the immediate post-operative period, something like 70% of the patients are either improved or unchanged, and about 30% of the patients are worse in the immediate post-operative period compared to where they started off preoperatively. When you look at the long-term follow-up, as in over 6 months or so, almost 90% of the patients are either improved or they are unchanged. So either they're back at their baseline, where they were before the operation, or they have improved. And 20% are worse. We had 4 deaths in the immediate post-operative period, and I can show you that slide. So this now is referring to the old series of 176 patients. The commonest thing that patients have when they wake up from these operations are issues with eye movement and double vision. So many patients have that at the baseline anyway, but there is a good chance that we will also make that worse as a result of the operation, but it tends to get better. And there are strategies that the way we operate, we try and, in the old times, many people used to go in the middle of your structure called medulla to get into these malformations. Now we go to one side to try and reduce that problem with the double vision. But it is something that is a common issue post-operatively. Also issues with walking, imbalance, weakness in arms and legs. But these tend to get better over the follow-up period. In terms of the 4 deaths that we had in our series of the 176 patients, one was a rebleed re-hemorrhage from a bit of the cavernous malformation that was left behind. Another one was a unrelated cardiac arrest before we even started the resection. And another one was a blood clot in the brain after the resection. So these are not, for obvious reasons, as you all understand, the deep-seated lesions are treacherous, and we do take them very seriously in terms of our decision to go in and operate. When we look at the long-term outcome over 6 months from that cohort of 176 patients, again, as I said, most patients, 82% or so, had a good outcome, i.e. they were either independent or they had minimal disability. And if you're in a good performance status, i.e. you're very good at the beginning, you're likely to remain in that group. So only 2 patients who were very good before the operation then had a poorer outcome over the long-term follow-up. And when we looked at our recent data, the things that predict who is going to do well versus who's not going to do so well, out of 286 patients, it was things like your age, so being either younger or equal to 40 years of age, preoperative performance status, same as what we found the last time, so if you're in a good performance status, and also the interval to surgery from the last hemorrhage. So we have consistently found that when we go in earlier rather than much later after a hemorrhage, we tend to get better outcome. And really, our hypothesis is because of the blood creating really an artificial plane around these malformations for us to go and work in. The other issue is, can these come back? And we have found certainly, so here's an example of a 4-year-old female with a large cavernous malformation that's occupying her brainstem, part of the thalamus, most of the thalamus, and surgically had a good result. She woke up with almost immediate improvement in her weakness on the left side of the body. But over follow-up period, you see further down the line, 2 years post-operatively, she had a recurrence. Now, we think it was recurrence because at least on the MR that we had, there was no evidence of cavernous malformation in the immediate that we did after the operation. So this does influence Dr. Steinberg's practice in the sense that he keeps, there's not a whole lot of evidence out there supporting that, but he does keep his patients with CAV-MAL who have had an operation under radiological surveillance, which has issues like Dr. Koh pointed out earlier. So in conclusion, really, with these deep-seated cavernous malformations, they have a high hemorrhage rate, and a large proportion of people who have these malformations do present with issues up front. And when we decide who to operate or not, it's a fine, delicate balance which takes into account how close is it to the surface, what is their performance status, and we tell patients that in the immediate post-operative period, there is a chance that you are likely to be worse, but over long-term follow-up, you're either going to be where you were or hopefully better. And this is the whole team, which includes people in the vascular surgery team, Dr. Steinberg, of course, Dr. Chang, and Dr. Dodd, and then our excellent nurse specialists. And these are all the residents and all the fellows. Thank you very much.
Thank you.
Are there any questions? Just briefly, we'll take a break and Dr. Abhinav will be here also for the panel at the end.
I could ask questions for hours. Some of the risks of the surgery while you're awake.
Yes.
I'm a patient, Dr. Steinberg's, and chosen not to have surgery yet. And I
Sure.
It's left temporal lobe, and he would do me awake because it's in the language, vision, and hearing. Right?
Sure, sure.
But it's not deep. You mentioned you know, take a long time deciding whether to have them awake or not. What are the risks? Are there more risks of being awake?
No, I don't. I mean, I think you need to be in a place where the surgeon has done awake surgery. So a lot of it is actually anesthetic considerations. So we need to have a good person from the anesthesia team because we need to be able to monitor the patient. Surgically, per se, it doesn't increase the risk for us, but the key elements are really having a good anesthetic team because you need to be relaxed because you do have to be woken up when we're doing that part of the operation. You have to have the other teams who are going to be giving you the language task or other tasks. And most important, as I said, the patients have to be on board because, some people, I've met many patients who are just not in with the idea of being woken up during an operation, and I sympathize with that. But technically and surgically, it doesn't increase the risk. And it gives us quite important information when we are operating more than, particularly for, this is not a brain tumor, but for many brain tumor surgeons, awake surgery is the gold standard because you get live feedback, straight away what's happening to the patient function, because all these other adjuncts, what we are trying to do is we're trying to minimize the chance of getting something wrong, but they have their own weaknesses. So when we use monitoring that I showed you, they also have their limitations, just as awake surgery does, but awake, is very helpful in telling us certainly about language tasks, even arm weakness, leg weakness, those kind of things as we're operating, and we can make real-time adjustments as a result. So operative risk per se, no, but those other considerations are important to address.
Do you have any regrowth rate stats on laser surgery versus surgical resection?
Even using the bipolar versus what we've done with the...
Yeah.
So we haven't seen any recurrence in what we've done so far, but if we have long-term data on that at this stage, nothing specifically. I don't expect it will be any different to using the bipolar in that sense, because even though we're using the laser, once we've done the initial part of the resection, sometimes we bring in the bipolar to do. What it's very helpful with is that initial approach, getting in, because my videos didn't play. I really had, when you use a bipolar, it almost is double the size, if not 2.5 times the size of the laser. And when your cuts are 3 to 4 millimeters, it's a big deal. It makes a difference. It allows us to work in even narrower corridor.
You consider 1 centimeter by 1 centimeter as a good for a laser operation?
Oh no, we work with 3, 4 millimeter, 5 millimeter cuts. If you want to make it extremely small, perhaps I can show it on my laptop later on.
He's asking about lesion size. Lesion size.
Lesion size. Oh, sorry. So say that again, please. So what? But if you have one, yeah. So that's a good question. If the lesion is big, you mean? So if it is in a very eloquent area, we still will start off with the laser, make the cut, go down to the abnormality, and try and do as much of it with the laser as we can, so you can take it out in small pieces. And then if there are parts that we can't, adequately take out with the laser, we can switch to the bipolar. But for the majority of the ones I showed in the brainstem, unless they're very large, usually with the laser, you can do the whole job.
You showed the graph in terms of immediate post-op, less than 6 months, and then long-term. I'm wondering, if you could advise on how long is long enough for a condition to stabilize. The reason I asked is my mom had a tonsil cavernous that was removed actually by Dr. Steinberg, and she saw the immediate post-op improvement, and then a strong decline long term. So I'm just kind of trying to gauge how long is long enough for us to recognize what her kind of ongoing situation would be.
Yeah. So I mean, in terms of the normally what we see is usually patients some patients do get better straight away, but like you said, some patients which was your mother's case, right? She got better to begin with. Normally, we don't see, I would say, a deterioration later on. So because even if patients have a degree of deficit or problem as a result of the operation of the cavernoma, usually over time, you see an improvement. And I would say, at least when we look at the follow-up data, we say anything over 6 months is good. So I would expect by 6 months, you would start seeing, where they're going to be close to the baseline. But patients get therapy and various other things, so they get improvement, but not as pronounced, I would say, beyond the 6 month period.
I'm checking that nobody else has another
Can
question.
you hold that one short, Pam? Okay. Let's take a short break of about 10 minutes, and then we'll regather, and Dr. Kim will speak to us for a little while, and I'll talk, and then we'll do a panel and have time for more questions. So we're running a little bit behind. About 10-minute break would be great.
All right.
Hi, everybody. Hey, my daughter just told me that it's like 3 o'clock and we're supposed to come back together now. She is inconvenient. She is. Come on back and have a seat.
Okay. Eat as we sit here. Oh, it is warm in here. I'm gonna put some water. Hmm? All places, but they're mine. Okay, we put the same place. Be frothy.
Our next speaker I've known for, I think, 10 years. We were trying to figure it out last night over dinner. I think it's been 10 years that Dr. Helen Kim has been at UCSF and, oh, I'm sorry. You know what? I got to change plans here. It's right over. Can you grab it? Okay. So, as I promised, right after break, we're doing a very special thing. If there are any UCSF patients here who would like to be part of the ceremony, this would be the time for you to come up. And then we could get a picture and express our appreciation for the great work that they're doing at UCSF. Dr. Cole, come on down. Dr. Hetz, come on down.
So UCSF patients.
And UCSF
Come on
patients.
up.
My
Come on.
doctor was Dr. But I'm not.
It would be nice to have some patients.
Come on down. We want one.
Don't be shy.
Yes, it does.
Yeah,
I've been gotten over the years.
No more
I count.
shirts today.
Law go against the law. Do you think that's a good
There you go.
over here? You go to law.
Yes, if you are a patient of Dr. Helen.
You got a light shining on you.
One time counts, come on. Come on.
Of course. Get in there.
Right.
Okay, so this is our opportunity to acknowledge the excellence that is to be found at UCSF. Our Center of Excellence program recognizes institutions that have multidisciplinary, integrated, high-quality care and also have an active research program. They have to see at least 50 patients a year that have CCM, which is a really high volume. And this is a group that absolutely has met the standard and gone beyond it. They see a ton of patients. They have both an adult service and a child service. You saw in Dr. Koh's slide the list of all of the physicians that are involved, and I think there are even more that she didn't fit on the slide. So, without further ado, I would like to present the certificate acknowledging and recognizing UCSF as a Center of Excellence. Oops, wait, one more. Okay. All right, thank you. Thank you. You get to keep that. All right, now Dr. Helen Kim has been with us for a really long time doing very important research for a very long time. She juggles many balls. Our
our chief scientific officer and I are always talking about how we don't know how Helen does it all. And she's going to share just a little bit of what she does with us today.
Thanks, Connie. Thank you for the invitation and that kind introduction. It's really working with great people. It's meeting the patients. We have a fantastic team of clinicians at UCSF that I collaborate, as well as around the world. And the Angioma Alliance has been instrumental in bringing scientists together from all over the world. And it's really been a fun, probably decade that I've been working on this. So I'm Helen Kim from UCSF, and I'm a genetic epidemiologist, this was mentioned, and I have been studying CCMs. Today I'm going to be sharing with you two research studies, clinical research studies that I've been involved with that speaks to clinical trial preparedness. Okay, so the first study I want to share with you is the Brain Vascular Malformation Consortium, or the BVMC. This is a study that's, that I co-lead with Dr. Leslie Morrison, a neurologist at the University of New Mexico. It's funded by NCATS and the National Institute of Neurological Disorders and Strokes, or NINDS. And we are currently in our 9th out of 10 years of grant funding. The overall mission of the BVMC is to conduct clinical research and trials to learn more about 3 rare vascular diseases, cerebral cavernous malformations, which I'll talk to you about today. But we also study Sturge-Weber syndrome and hereditary hemorrhagic telangiectasia. And the overall goal of this consortium is to develop new and better treatments to improve the care of patients living with these brain vascular malformations. So I don't need to do too much background because Dr. Ko and Abhinav have already set the stage, but just to highlight just a few things that we've already talked about CCMs as a problem with capillary dysplasia and overgrowth. They have this leaky blood-brain barrier, so blood oozes and fills these caverns, these bubble-like caverns. And so you can see that from the middle picture. And these blood-filled caverns are in various stages of thrombosis and repair. And that's what the blood, or the iron in the blood, is what's detected on MRI. So here you can see an MRI sequence using iron-sensitive sequences, and all of those little black dots represent cerebral angiomas, or cavernous angiomas. And we've also talked about the various clinical manifestations of the disease. The primary reason to intervene or treat CAV-MALs is to prevent cerebral hemorrhage, which occurs in about 15% of patients at initial diagnosis. And there's still currently no primary medical therapy available for treating these lesions. However, I think within the next 5 to 10 years, we are very hopeful about bridging that gap and having the first clinical trial to bring medical therapy to CCM. So Nerissa already showed this slide, but I just wanted to point out that the Brain Vascular Malformation Consortium CCM study focuses on familial cases because there are some slight differences. So again, just a reminder, familial cases are inherited. So there is a gene mutation in one of the 3 known CCM genes shown here. And these cases tend to have a more severe phenotype or have multiple manifestations of the disease. So meaning that they have multiple brain lesions, but they can also have lesions in the spinal cord, skin, and retina. And one of the many challenges of studying CCM is that there's huge variability in the phenotypic expression of the disease. And that makes it very difficult because it's hard for us, for the researchers and clinicians, to identify which patients are the ones that are going to go on to hemorrhage, right? Because those are the ones that you want to intervene on. And so we already showed this example of the disease severity. I love this example because you can see not only striking differences in lesion burden after controlling for age, after controlling for gender, after controlling for genetic mutation, because these all have the exact same gene mutation, and yet you still see this huge variability. And so that's what really led us to design the BVMC study. We hypothesized that there must be additional genetic or environmental modifiers that it can explain this variability in phenotypes that we're seeing in familial cases. So in terms of disease severity or lesion burden, and also disease progression to eventual clinical symptoms. So we would like to be able to intervene before patients even develop clinical symptoms. So this is, so these are kind of the specific aims of the BVMC grant. So aim one, we've been enrolling and following a cohort of patients with familial CCM over time to characterize the phenotypic expression and natural history of the disease. And this information is important because it provides important information that will hopefully help clinicians weigh the risk benefits of treatment. Right? You need accurate estimates or predictors of outcome events to be able to say whether or not that person's at high risk or not. Aim two, where we are collecting blood samples from patients and performing genetics studies to identify modifiers, specifically focusing on the role of inflammation in disease progression. And in aim three, we are following a subset of patients, bringing them back up for repeat imaging to see if we could use imaging biomarkers to predict disease severity and progression. So we've been enrolled about 470 patients to date. The study has been conducted in 2 cycles. Mainly that's because of grant funding. NIH only gives funding in 5-year increments, so we're constantly applying for renewal. And there's been several differences in the 2 studies. So in the first cycle, BVMC1, we focused on a very genetically homogeneous cohort of patients. So these were all recruited from the University of New Mexico. And they all had a mutation in the CCM1 gene called the common Hispanic mutation. And Dr. Ko already talked about that. This is a founder mutation that affects patients in the southwest states of the US, as well as in the northern states of Mexico. And so there's a very high prevalence of this disease in those areas. So it's a huge public health burden. So we thought that it would be nice to start with this type of study because we're removing heterogeneity from genetic causes, because they all have the exact same gene-causing mutation. We also brought these patients back for detailed neurological exams and a research 3T MRI scan. And because we're recruiting based on genetic status, a lot of these cases were actually asymptomatic, right? So they know they've inherited the gene mutation, but they may not necessarily be manifesting symptoms yet. In the second BVMC cycle, we expanded to recruit not just CCM1 patients, but all familial CCM patients. So including known genetic carriers of CCM1, 2, or 3. And we also expanded, and also enrolling based on clinical diagnosis. So if you have multiple cavernous malformations and a strong family history, you would be eligible for this study. We also increased recruitment sites from UNM to also include UCSF, the Barrow Neurological Institute, and the Angioma Alliance. So we work very closely with Angioma. In this current cycle, we are relying on clinical exams and diagnostic MRI scans for clinical phenotyping. And it's the majority of these cases in this cycle are symptomatic cases. So there are some differences in the 2. So what have we found to date? So interestingly, it takes a long time to accrue data. Studies, I know patients are often asking, when are we going to get results? And I have to say, I wish I could give results faster than I do, but it takes a lot of man hours to put this data together, to clean the data, analyze the data. And so one of the first studies we looked at was looking at cardiovascular risk factors to see if that was associated with disease severity. And interestingly, so prior to this, only increasing age, so older age, we knew was a risk factor for increasing lesion burden. That's been known for quite some time. It's been reported in several other cohort studies. But in addition to increasing age, the only other risk factor we found was actually obesity. And in fact, it was an inverse association, which was surprising to us, in that obese individuals seem to have fewer lesions at baseline compared to non-obese individuals. So that's not
the right message, I want to say. It's okay to be obese. That's not what we want to say. And we struggled, right? We struggled. Well, what could this mean? Yeah.
My first thought is a higher fat diet, could that help?
It could be. We're going to come back to this. We're going to come back to this later in the talk, but nonetheless, we speculated various reasons, and we ended up publishing this data in 2014. I think this is going to be a nice story. It's going to come together in the end, and that's what science is all about. You never know where the data is going to take you. So we also have confirmed, at least in our common Hispanic mutation cohort, that there's a very high prevalence of cutaneous skin lesions or spinal cord lesions, and maybe even higher than what's been previously reported. And finally, we've also reported some novel findings where there seems to be an increased prevalence of T2 white matter lesions in common Hispanic mutation cases compared to controls. And also they seem to have a high prevalence of these small focal adrenal calcifications, which may represent a silent manifestation of the disease. So in other words, if you have a familial form of the disease, it makes sense, right? It affects multiple organ systems in your body, right? Not just the brain. So we've always been focused on the brain because that's kind of what we study from a neuroscientist point of view, but also, you know, that's what we've been worried about from a clinical point of view, is trying to prevent that severe manifestation with a hemorrhage. As part of the study, we've also been following patients annually by phone to get updated clinical status. And so we're able to actually calculate hemorrhage rates during follow-up. And so in our cohort, we've had 13 hemorrhage events reported during the follow-up period. And this allows us to calculate the rate, which is about 3% per year. And 3% per year is actually, it's going to play a role when we start thinking about designing future clinical trials, because in actuality, a 3% hemorrhage rate is quite low. You know, it's not low if you're the person having the hemorrhage, but in the general population, we are going to have to recruit lots of patients to be able to demonstrate efficacy for future clinical trials. So that's kind of been something that we've been thinking about as a community for quite some time, is how are we going to do that? Because clinical trials are really expensive. On the order of $30 to $40 million to get all the way from phase 1, 2, 3, you know, to phase 3 studies. So we'll come back to that. I'll give you some numbers later. We've also been looking at lesion burden as a potential predictor of subsequent hemorrhage. And to that point is we're trying to figure out if we can use alternative phenotypes as surrogate endpoints for clinical trials. So maybe we don't have to wait till the patient has a hemorrhage event, but if we could power the study on a quantitative phenotype, we probably would have need far fewer patients to be able to demonstrate efficacy. So our preliminary data suggests that this might be feasible. However, currently the rate limiting step is that our study neuroradiologist manually counts all of these lesions. And if you remember from the first slide, some patients have hundreds and hundreds of lesions. You know, I think the maximum was like 700 something brain lesions. And you can see that that's prone to a lot of error over time, counting each slice. But also it's not practical in a clinical setting. So we've been working at UCSF to try to develop some automated algorithms to process this. And then also that would be helpful clinically, because if we could run this on clinical scans, we could easily say, you have a new lesion, you know, we have a baseline scan for any future lesions. With respect to AIM2, we've actually reported several genetic modifiers of disease severity. And again, we focus primarily on inflammatory immune response genes. This is based on prior work looking at tissue and tissue studies of resected CCM lesions, suggesting that inflammatory and immune response is inherent in perhaps in tissue. So this just summarized 3 of the severity phenotypes that we've looked at: history of intracerebral hemorrhage, the total number of large lesions, and the total number of lesions. And as you can see, I tried to summarize the data. I'm not showing you a bunch of numbers in our paper, but kind of the key genes or variants that we found in genes. So for example, some variants, like in the toll-like receptor 4, CD14
CD14 gene are only associated with one phenotype, whereas there's others, CD14 and CD68, which are markers of macrophages and monocytes, important inflammation, but are associated with two phenotypes. And polymorphism in the TGF-beta receptor 2 gene was associated with all three phenotypes. So we think that this provides important information. We can't ever prove causality in humans. You need animal studies to study mechanism and stuff. But this really suggested to us that inflammation really does play a role in disease progression in humans, because we have, starting with new lesion formation to lesion growth, total large lesions, to eventual clinical symptoms. It also kind of potentially highlights some important drug targets for slowing the progression of the disease. So if inflammation plays an important role, can we dampen inflammation or immune response to slow the progression of the disease? So I'm going to spend a little bit of time and show you some actual data from the toll-like receptor 4 and CD14 story. I think most of you, or many of you in the room, may have been aware of the Nature paper that came out last May, linking the gut microbiome to CCM disease. And so I'm going to just summarize that quickly, because even I have problems reading, understanding all the data that's in that paper. It's pretty dense. And I'm a co-author on the paper. So one of the important things, so this is work that was done in collaboration with Mark Kahn's group at the University of Pennsylvania. And Mark Kahn is the senior author on that Nature paper. And Mark had approached us at one of the CCM scientific meetings a couple of years ago, because he had developed an animal model for CCM and had been studying the mechanism for it. One of the things that's not clear is, even though we know the genes and the proteins involved in familial CCM, it's not really clear how mutations in those genes or proteins, or loss of those proteins, actually leads to CCM formation, right? What initiates the disease process, and what initiates symptoms, right? Because not everybody has symptoms. And so we went back to our data, because Mark had really been interested in toll-like receptor 4. And it turns out that the variants that we had published in 2014 in toll-like receptor 4 and CD14 turned out to be functional variants, which was very interesting, because this suggests not just an association, but there may be a real functional role. So animals are not the same as, or mice are not the same as humans. And so this is really providing clinical relevance for what Mark was seeing in his animal models. So what you can see here are these scatter plots where increasing number of copies of the risk allele corresponds to increasing blood expression levels in healthy controls for toll-like receptor 4 and CD14. So those were the two SNPs that we were interested in. And furthermore, that these genetic modifiers, if you will, increasing copy, so you can't really see, but increasing copies of the risk alleles, either in TLR4 or CD14, was associated with the increasing lesion burden severity, as you can see in those figures from left to right. And Mark was able to show that in his animal models, that if you deleted toll-like receptor 4 from endothelial cells, that all of a sudden now you could actually prevent lesion formation. So this is really linking toll-like receptor 4 as important for the mechanism leading to CCM lesion formation. And furthermore, they went on to show that administration of anti-TLR4 drugs, two drugs here, could also reduce lesion formation in their animal model. That's shown in the second and bottom panels there. So suggesting a potential therapy that may be beneficial if you can target the TLR4 pathway in humans. And perhaps what was most interesting from this study was this link of the gut microbiome to CCM disease. This had never been thought of before. And so how could something in the gut affect what's going on in the brain, right? And part of this has to do with toll-like receptor 4 in general. It is a signaling marker. It's involved in the innate immune response. So it's meant to be a sensor of what's going on in your body. And so we know that LPS, which is lipopolysaccharide, is a key component of gram-negative bacteria. It is one of the most potent activators of toll-like receptor 4. and then innate immune response. We also know that gram-negative bacteria are a major part of the gut microbiome. We have both gram-positive and gram-negative bacteria. And so they had hypothesized that maybe some of these differences that they were observing in their mouse colonies between susceptible strains that developed lesions versus resistant strains that all of a sudden were stopped developing lesions might be due to differences in the gut microbiome, so different bacterial content in the gut. And they were able to test this by comparing the fecal contents, so the stool, the poop, essentially, from these mice in these two strains, using a technique called 16S RNA sequencing. And lo and behold, that is exactly what they found. They found a much higher abundance of this species called Bacteroides S24/7, which is a gram-negative bacteria in their susceptible mice versus resistant mice. So this was a really nice story because now it seems to think about, well, what are some of the things that we can do if the gut microbiome truly is involved in CCM disease? One, we have to test that in humans. And secondly, there's potential therapy again. If we can alter the gut microbiome with antibiotics, that's an easy, right, therapy to test. So this led us to conduct a new pilot study that is ongoing right now. So the BDMC study, I told you, is in our 9th year. We're continuing to recruit and enroll patients. And so as part of the BDMC, we're also now doing a pilot study of the gut microbiome to try to generate some preliminary data so that we can submit a larger grant to really study the role of the gut microbiome in familial CCM. So if you're enrolled in the study or interested, please contact me later. You just have to be able to provide a stool specimen, fill out a short food frequency questionnaire, and be able to provide clinical imaging scan data.
Why is it only familial, not sporadic as well?
Yeah, so we want it because of the animal models. It's really looking at lesion formation. The idea is that it's the disease lesion burden, right? So we can only really study that in humans with the familial forms of the disease because they are developing new lesions over time. So the goal here would be, the therapy would be to prevent new lesion growth.
Chicago.
But Chicago is also including some sporadic cases as well. Right now, currently, this is an unfunded study, so we had to start with consolidate our resources, and since we already have an ongoing study focusing on familial cases, we're currently not recruiting the sporadic cases until we get additional funding, because these experiments are actually quite costly to do RNA sequencing. But eventually, yes, we would like to include the sporadic forms as well.
You, in the initial studies, show that like what you're eating works. Like, what do you recommend you eat? Like acidophilus or certain types of?
Yeah, yeah, that's actually a good question. You know, I think there's a lot more work that needs to be done on that. I think the general feeling is that, you know, probiotics might not necessarily be, you know, what's out there right now may not necessarily work. We really need to identify what species is really prevalent in the gut to be able to maybe have a cocktail or something that would really. But you know, anecdotally, you know, there have been patients that have had GI like Crohn's syndrome or IBD, irritable bowel syndrome, or things. And I know we've had some patients that have had to completely change their diet, and then they have had reported less seizures, for example, just from changing their diet. So these are all anecdotal stories, and we really need to test it scientifically. So that's what these studies are moving towards. All right, so in the last couple minutes, I want to talk about a new study called the Trial Readiness in Cavernous Angiomas with Symptomatic Hemorrhage, or CASH. It's a mouthful. This was recently funded and started December of 2017. And the overall PI is Osama Wad from the University of Chicago. And I'm going to talk about this grant because this is also a demonstration of the scientific community coming together to try and make sure that things are moving in parallel, because the animal studies and the mechanistic studies have been ongoing for quite some time now, and we're trying to catch up on the human side of things. So the rationale for the CASH trial is that we really need to think seriously about who we're going to be targeting for the first randomized clinical trial. As I mentioned, clinical trials are quite expensive to get to that point, and many clinical trials actually fail. And why do they fail? Partly it's because the assumptions going into the trial were incorrect. Partly they don't get buy-in from, not only you have to have, as patients, be willing to be randomized into clinical trial, so agree not to take a drug, for instance, but you need buy-in from the medical community too, that the providers are actually willing to randomize their patients to clinical trials. So there's a lot of different factors that come into moving into a phase 3 trial. So after much discussions at the Angioma Alliance scientific meetings, we decided to focus on these CASH cases, so the cavernous angiomas with symptomatic hemorrhage. Because, as Dr. Abhinav pointed out, and I will also show a slide, these are the lesions that are most likely to rebleed. They have a much higher rate of rebleed. They're also the ones that are most difficult to treat surgically, especially if they are in deep and brainstem location. And you can actually cause some poor outcomes or permanent neurologic deficits. And again, I mentioned the clinical equipoise, and also that there's many, actually several candidate therapies currently under development for application in CCM, and I'll show a slide in a minute too. So this is just a summary of the previous published studies that have reported annual hemorrhage rates in CCM. So again, we're focusing on these hemorrhage rates, and Dr. Abhinav had a similar slide in his study. I just oriented this slightly differently. So if you look at the middle column, first ICH, these are cavernous angiomas that have previously have not ruptured. So they were identified for other symptoms such as seizures, headaches, or other symptoms, but have not bled. And what you can see is most of those dots to the right are pretty close to the line, right? So it's actually a very, very low rate of hemorrhage in the follow-up period of these studies, on the order of about 1% or less, which again has huge implications for future clinical trials. Whereas if you bled, so this is now the bottom studies, the recurrent ICH, you can see there's much higher rates, but also huge variability in the reported rates of hemorrhage for rebleeding after you've initially already had a bleed. And so that's one of the main reasons why we're doing the study. Yes, we have an increased rate if we focus on this subpopulation of patients, but we don't know what that rate is. It's all over the place, right? So we really need to conduct a prospective study at multiple sites to really get a handle on an accurate estimate of what that will be, because that will be needed for the trial. And this is just some numbers based on this, the sample sizes that are needed based on varying your event rate. So again, this is actually a 6% event rate. So the 6% hemorrhage rate would require over 3,000 individuals to be enrolled in the randomized controlled trial to be able to demonstrate a 25% risk reduction in the treated group, whatever treatment, your medical treatment or drug treatment you're going to be doing. And that becomes not practical, right? Again, these trials are extremely costly. So what can we do? If we focus on the group that's most likely to have much higher event rates, which is those who presented with the bleed initially, then now we're talking in numbers that are feasible. 435 or 98 subjects would be needed to demonstrate significance between the two groups. And also there's a number of drugs that have been, are in the pipeline for CCM use. Again, these are all preclinical studies mainly, so done in animal models or in vitro cell culture studies. And these drugs, many of these drugs are already FDA approved for other indications. So I imagine within the next 5 to 10 years, one of these drugs will be available and ready to be tested in humans. And the other thing is that they've all been shown in the animal studies or the in vitro studies to rescue the phenotypes, the abnormal vascular phenotypes seen in the disease. So really promising and really exciting right now, I think. And so the trial was really, this trial readiness grant was really designed to kind of address these knowledge gaps. What is the prevalence? So I showed you that there's huge variability in the rates. Can we demonstrate that we can enroll these patients at multiple sites? Do they differ by demographic or clinical characteristics? What are the functional status or quality of life instruments that capture the clinical impact of these cases? I haven't really talked about this, but somebody already mentioned this. It may not be that hemorrhage is not a concern for patients, maybe, and it's mostly maybe seizures, the recurrent seizures, or the debilitating migraines headaches that really affect your quality of life. And from a patient point of view, that may be the most relevant outcome. And so we're trying to figure out how we can incorporate patient-reported outcomes into clinical trials and be able to use those as endpoints, perhaps, that the FDA would approve. And then finally, also, can we use imaging biomarkers as a surrogate endpoints? And certainly we can use them to monitor therapeutic efficacy. So here are the three specific aims of the grant. Again, aim one is really just to get a handle on what are the rates of cash cases in this study. So we're going to be recruiting patients from 5 sites, the University of Chicago, Mayo, the University of New Mexico, Utah, thank you, Connie, and Barrow Neurologic Institute, and then UCSF and Hopkins are alternative backup sites. And really standardizing common data elements that we'll be using in the clinical trial, in the future clinical trial. And so I'll be leading this through the Epidemiology and Data Harmonization Core at UCSF. And our goal is to enroll 200 cash cases over a 4-year period. So while 200 cases doesn't sound like a lot, again, this is under the assumption that it's a 15%, we're being conservative, prevalence of cash cases seen at any of these 5 sites. And so we're going to have to screen over 1,500 cases, cavernoma cases, over the next 4 years at all 5 sites. So that just kind of illustrates that we have to do much more if the rate's lower. Aim 2 is testing the feasibility and reproducibility of measuring imaging biomarkers as a potential surrogate outcome, and this is being led by Summer Watt's group at the University of Chicago. And the goal here is to enroll 120 of those cash eligible cases into the prospective study where they'll be followed up annually with imaging. And here, somebody actually asked me a question earlier. We are using research sequences, so this will entail contrast, and it's based off of Sam's prior work demonstrating that iron, so quantitative susceptibility mapping measures iron content, iron concentrations, and DCEQP measures permeability. These are two key features of the CCM disease that we know are relevant from a biological standpoint and from the mechanistic studies. And so aim 3 is then to determine rates of clinical hemorrhage versus changes in these imaging biomarkers and potentially patient-reported outcomes or quality of life outcomes during prospective follow-up. And this is being led by Kelly Fleming at the Mayo Clinic. So this is a very busy slide, but I just put it up here to say that this, again, is all movement towards trying to build the research infrastructure and the network of sites that will likely be used in the future phase 3 clinical trials. It's not to say that other sites will not be involved. It's just we want to be prepared. So the goal is to, at the end of the 5 years of this, that we'll be ready to launch, and we've demonstrated that we can work together. We have standardized data collection. We have all the kinks worked out, if you will. And we're running this like a clinical trial. So we have an advisory committee here. You can see a little bit small, but we have representatives from biopharmaceutical companies. We have clinical trial experts, and we have Connie Lee from the Angioma Alliance representing the patient concerns for the trial. And so quickly, just to go through, so to be included in this study, we're focusing initially on adults, so those 18 years of age or older diagnosed with a brain cavernoma, single or multiple. So this trial readiness study will allow both sporadic and familial cases, not just the familial cases. But you have to have a symptomatic bleed within the past year. It's defined as new lesional bleeding or hemorrhagic growth greater than 3 millimeters and attributable to new clinical symptoms, and no prior treatment of that symptomatic lesion.
And you need to be in one of those 5 centers.
Pardon me?
And you need to be in one of those.
And you need to be at one of those 5 centers, yeah. You see. There are several exclusion criteria that I'm showing here. I'm not going to read them all. You can see them yourself. So that the top part is for the AIM-1, and then further exclusions for the people that are in the prospective follow-up for AIMS-2 and 3. We'll also be collecting standardized data from patients. So again, this is not an interventional study. It's preparing us for future studies. But I just wanted to mention again the scale issue because it's come up a couple of times. So we're actually collecting a number of patient-reported outcomes. So the EuroQual is a very simple, how are you doing, health status, 5 questions. Similar to the modified Rankin Scale score, which is a provider opinion of how you're doing, which is the modified Rankin Scale score. You know, the trade-off is always in sensitivity versus specificity. I'm not sure that, so the modified Rankin Scale score is commonly used as an endpoint in clinical trials, but if you work with the data and you talk to people, I don't necessarily think it's the best measure because it really just captures global disability, so functional disability. Are you able to walk? Things like that. It doesn't capture the subtle disabilities. And so we're also using PROMIS 29, which is a version of the abbreviated version of the NeuroQual quality of life that targets various domains, including anxiety, depression, pain, and cognition, for example. I think in limited time, again, just this is meant to say this is a run like a clinical trial. We have very specific milestones and a go, no go plans. And really, it's just run like this because we want to be ready for clinical trials at the end of the 5-year period. And I think some of you may be aware that the first phase 1/2 study has been recently funded by NINDS to test the safety and efficacy of atorvastatin, which is a type of statin, for CCM. So this is the first trial, kind of real trial in humans, and this will begin probably this fall. It's a single center study at the University of Chicago, but they are allowing patients to travel. There is some stipends in there for travel reimbursement if this is of interest. And you can find more information from that clinicaltrials.gov website. So I probably went over time. I'm sorry. Thank you very much for your attention. There's just so much to share, and I don't have enough time to share everything. So thank you.
In the interest of time, we don't get to ask Helen questions.
I'll just do it for the panel.
Yeah, we have about, hopefully we'll have a panel. Can we just move that up? Stephanie's gonna buy them. Anyway, my talk today is a little bit about what Angioma Alliance does. And I think the title of it is something along the lines of the Angioma Alliance mission and how you can be part of it. I didn't do that first slide. It was like this whole time. I know. Angioma Alliance mission. Yeah, just hold up. I mean, sorry about this.
For those of you that didn't sign in, I'm gonna put the sign-in sheet at the door. If you could please, on your way out, make sure that we know you were here. Thank you.
And this is, by the way, Stephanie Alband. All right, so what you need to know about Angioma Alliance. Angioma Alliance is really, really small. As much as you're gonna see a list of about 30 different things that we do, Angioma Alliance has 3 employees, 3 full-time employees. And you're seeing 2 of them right now. It's me, it's Stephanie Alband, and it's Dr. Amy Akers. Here we are. Okay, I paraphrase. And so that's why involvement of other people is really important. But the first thing that I wanted to just, again, Helen put her slide up. Mine is more colorful than hers.
It's nicer too.
Well, actually, this is Amy made this, so I can't even take credit for it. 10 years ago, there was nothing. That slide would have shown Zippo 0, nothing. In the last 10 years, there's been enormous progress in the number of drugs or potential treatments that are out there and how far along they've come. So we know, as Helen mentioned on Tuesday, we announced that atorvastatin is entering clinical trials. It is the very, very first medication to be entering trials for cavernous angioma with symptomatic hemorrhage. There's also a propranolol trial. Propranolol is an existing drug that is a beta blocker. It's been out there for many, many years. It has great safety data already for it. For other indications, at the University of Virginia, they're doing work on that. All of these other drugs are probably going to be coming into trials in the next 5 years. If they're not, some of them may never come, like vitamin D3, because it's hard to control how much sun people get. But the ones that are there that are medications that would become prescriptions are in the next 5 years. So that's something to celebrate. Definitely something to celebrate.
Mm-hmm.
So what do we do as Angioma Alliance to facilitate the movement of that chart, but also to help the folks that are currently experiencing symptoms from the illness itself before there's anything else available? So for us, one of the things that we put a lot of money into lately is free genetic testing. Anybody who has multiple lesions that can't be explained by a DBA or a history of brain radiation can get free genetic testing through us if their insurance company won't cover it. We create patient educational materials. You guys have seen our booklet. We have a website that is as extensive as anything that you're ever going to find. And we do videos on our YouTube channel. Please look for them. We have our Center of Excellence program. You just got introduced to that. We now have 1, 2, 3, 4, 5, 6 centers. And I think probably by the end of the year, we will have another couple. We have our scientific advisory board, along with other invited experts, created the standard of care. They created clinical care consensus guidelines. It was a 3-year project to try to get a standard by which doctors could make decisions. So it's divided into different categories, like what should a geneticist do? What should a radiologist do? What should a neurosurgeon do? How do we make these decisions? What are best practices? That was done through Angioma Alliance, and Amy Akers coordinated that process and was the first author on that program. And then outreach in New Mexico, that's me, and we actually have a 4th employee that I don't mention usually in these settings because she's only in New Mexico. We have the Baca Family Historical Project, in which we bring together people based on genealogy, not necessarily the illness. We've done a lot of work in New Mexico for many years, and we've scared far too many people by saying, let us come up to you and talk to you about this really serious illness that you might have. And they run from us, and I've never understood that. But now we have a new project that I'm really proud of, in which we just appeal to the general public based on the idea that the Baca family is a really cool family, and everybody who's a Baca should get to know each other. and we bring them together. We share information about the history of New Mexico. We share information about the impact of the Baca family in New Mexico. And we're now moving into El Paso. We're going to hopefully get into Chihuahua in Mexico and other areas. And then we say, and by the way, some people in the Baca family, a small segment, may have this illness. And if you are interested in genetic testing for this illness, we can offer it to you here at this conference. Not here for you guys, but in New Mexico, we offer the genetic conference on site, the genetic testing on site. For research, we are the organizers and hosts of the annual International Scientific Meeting. Anybody in the world, usually we have people from 4 continents who does research, they come to our meeting. If they don't come, they miss about a year of progress in science because we only allow people to share new information, not information that they've had out there and published for a while. We are the major source of tissue for laboratories around the world. When you have a surgery, if you have a surgery plan, please let us know so that we can try to coordinate the transfer of the tissue, the cavernous angioma itself, to our tissue bank. We have a patient registry. Everybody in here, if you are affected, or if you have an affected family member, the affected folks should be in our patient registry. That's how we communicate about research. That's how we learn more about what our population looks like. We were just awarded a grant in order to upgrade our registry so that it's going to become even more useful to researchers. Researchers are going to be able to access it directly, seeing only de-identified data. They won't know who you are, but they will be able to ask questions in the data and try to get some answers without having to go through us. And as Helen Kim mentioned, we're an IRB-approved enrollment site for both BDMC and for the microbiome project. And then finally, we help a lot with industry now. We have been doing this more in the last couple of years as pharmaceutical companies are beginning to consider CCM as a possible indication for a drug that they want to develop. We get involved. We try to see what we can do. For some, it's helping them connect with our patients so that they understand the illness better. Isaac Babs here knows for some it's a matter of helping them figure out how to make a company out of what they're doing in their garage. It's really grassroots. BioAxone, who's developing BA1049, we brought them in. They were developing a drug that we knew that it had a little bit of potential or had some potential for CCM, but they didn't know it. So we contacted them and said, hey, have you ever heard about CCM? Would you like to be more interested? And they picked up on that. And now this BA1049 that they're developing, CCM is the primary indication for. Patient support and empowerment. We have, of course, a very supportive online community that most of you are part of, and also a community forum on our website. And we still do offer one-on-one peer support. We do conferences like this. And November 9th, Silver Springs, Maryland, be there. We're going to have our National Family Conference, if you can make it. And this year it's happening at the same time as the scientific meeting. So the cool part about that is anybody who comes to that conference is also going to be able to interact with the researchers that are there. And we have opportunities to engage. We have a CCM CARE Act right now is in committee in the Senate and in the House, and that helps us to get our name out in front of legislators. And now, most newly, and that's why I spun in there, did you guys see that? I'll do it again. There you go. We have Community Alliance, our new Community Alliance program. And what this is, are structured groups, and they're going to be regional groups. We have 5 of them already that carry out the mission of Angioma Alliance in their locality. And again, what I said first was, there's 3 of us. There's 3 of us on the national level, and that's just not enough people to do everything that we want to do or need to do in order to get to care, to treatments, to care. And so that's where these community alliances come in. We now have an alliance in the greater Washington, D.C. area. We have one in Florida, the Pacific Northwest, Stephanie, we're at Colorado, what did I forget? There's one more. Oh, the tri-state area. And we want more. And so we would love to have one in the San Francisco Bay Area or wherever it is that you live. Southern California, we're trying to get one going there. You need to talk to Stephanie if you haven't already. So our mission as an organization is to inform, support, and empower those affected by CCM and drive research for better treatments and a cure. That's what we do. And that's what anybody can do in their neighborhood. You don't need to be doing it on the national level. You can do it at your local hospital, at the health fairs, with the people who are around you that are affected, and even with your local researcher. You can take them out to dinner. I mean, seriously, they like us. They want to know us. And it would be, it's just a good thing to develop relationships and let people see how much you appreciate them. The one thing I do want to mention here, and we're in the middle of a branding project. Actually, we're at the beginning of a branding project. The pharmaceutical companies have come to us recently and said, we are trying to get investors, we're trying to get bigger pharma companies interested, we're trying to get other types of investors interested, and you guys have way too many names for your illness, so we need to narrow that. The American pharmaceutical companies have told us that Angioma is actually the name that works best for them when they're trying to sell what they do, because people can, or other pharmaceutical companies, investors understand that Angie means blood vessel, Oma means benign tumor. You put it together, it makes sense. So we are hoping to be able, over the next few years, to shift people to saying cavernous angioma, and then perhaps in parentheses CCM, because we're stuck with the gene names. But just so you know, we're going to keep using it, and this is the cavernous angioma with symptomatic hemorrhage is something that's not going away either. So the community alliances need to have 5 different families, and we try to get them structured into a chair, a co-chair, a treasurer, a peer support chair, an event chair, and then beyond that, it's whoever wants to participate. They are intended to serve as a resource for newly diagnosed people. They need to meet 3 times annually, but only one of those needs to be in person. The geographic areas are fungible. Really, I think Northern California is a very natural geographic area. I also think Southern California is a natural geographic area. Some of our groups are smaller. They're just like the Washington, D.C. area. They just have one city. And then some of them are big, like Washington and Oregon are together in one group. So it really is what makes the most sense organically. Each group develops an action plan of mission activities. So what is it that your group wants to do? Start small, make it possible. And also fundraising activities. We ask that the groups commit to doing one fundraising event annually with a goal of raising $5,000, which sounds like a lot to some people, but probably doesn't faze other people at all. And that's why we want to have a nice mix of people. All right, so at this point, please take out your cell phones and take pictures of these slides. I don't really need to go through all of them. What I do want to say is, while you're taking pictures, take out your phones and take pictures of these slides. I'm asking you to do that. What I do want to say is that I have been running Angioma Alliance for 16 years. When I started Angioma Alliance, I had a 3-year-old, almost 3-year-old, who had been through 3 brain surgeries. It's now 16 years later, I'm still doing this. It is amazing what this mission has brought to my life. I'm grateful every morning for being able to do this, and the only reason that I can do this is because we have donors who support what we do. But I also want to tell you that that 3-year-old is now 18, and next Saturday, she's going to be graduating from high school. And she's trying to keep her head down so that she's trying to keep her head down. But I just want to tell, especially those of you with little kids, as hard as it can be, and we wound up having a 4th brain surgery after the 3rd brain surgery, as hard as it can be,
it continues, it's good. It may not be the same parenting that you expected to have, but it's an amazing journey. And I'm now, at 18 and at the end of the high school road. We have plenty of more story left to tell each other and to share, but you guys, a lot of you have made that possible for us. And I think this is my last slide for you guys. Take a picture. Okay. Everybody good? Oh, I'm sorry, one more, surprise. And this is what we do, how the groups can help with research, and which means please sign up for the patient registry and make sure anybody else you know get connected to it. All right, final takeaways. With the announcement of the clinical drug trial and the advancement of other research, we are at a crossroads now. The last week has felt different to me. The last week I've seen differences in our community. Yes, it's the beginning of Cavernous Angioma Awareness Month. If you didn't know that, that's June. Check with Stephanie for all the ways that we can be helpful with that. But it does literally feel like we've moved into a new zone. And we will be successful moving forward into treatments if, and only if, we mobilize together. I can't do this alone. Amy and Stephanie and I can't do this alone. It requires you as a community to come together and be part of it. We have a lot of ways for becoming involved. Those last 3 or 4 slides that you just took pictures of, that's part of it. Be part of a community alliance. And if you want more information, contact me, contact Stephanie. There's a volunteer interest form on our website. And realize that without you, there is not going to be a cure. And I think that is it, aside from the thank you. So I want to thank Jody and Isaac Babs because they were a large part of our being able to meet here today. The Center of Excellence staff at UCSF, Stanford for allowing us to have Dr. Abhinav here today, and the Silicon Valley Community Foundation for this space. So that's it. Stephanie, tell me about time.
I think we're pretty much over, but we're good.
Can we have like maybe 10 minutes of questions for our panel?
Sure. I mean, she's not yelling at us yet.
Okay, she's not yelling at us. Don't tell her. Nerissa, Helen, Kumar, can you guys come up for a minute and just pull up some chairs? Okay, questions?
Okay. I feel bad. I have so many questions. Of course, I have everything. We'll try to narrow it down. I see lots and lots of emphasis on drugs and no emphasis on diet, and I understand the whole economics of why that may be. It seems like fundraising seems like the issue there, maybe for studies regarding diet. Like you mentioned with those saccharides, that they're bad for the, well, anyway. Okay, let me narrow this down with like a D3 question. I recently found out that you're supposed to take some K2 with D3, otherwise you can calcify your blood vessels. Does anybody know, is K2 safe? Because it's has the opposite of a blood thinning effect, so you'd think it'd be safe for people with angiomas.
Can you repeat the question?
Yeah, so obviously the vitamin D story you've seen in a lot of diseases, not just related to CCM. I think it's one where, it turns out to be maybe a common pathway that modifies our immune system or other things in the body. And I think one of the challenges is that it's hard to determine the effect because people live in different levels of sunshine. Vitamin D is modified by so many things. And so I think it's not just that people aren't interested in it, it's incredibly challenging to study. And then there have been these issues with, and I think this is one of the hardest parts because we have such few opportunities to study things rigorously and well. if everybody just started doing vitamin D, I don't know if we'll ever know the answer in the right way. And so I think this is one of the things we have to really think about, and certainly with, you know, being thoughtful about what is the right thing to do. I certainly don't think doing vitamin D supplementation for regular kind of doses is harmful. Often in the Bay Area, we don't get enough sunshine and everyone's vitamin D deficient. But I think when we're talking about treatment doses for an effect, then I do think we're not sure what could be harmful for folks. And now we're talking about mixing and matching things, and I'm always fine with folks trying things, especially when there hasn't been a treatment ever. And I think as long as it follows the path of safety and nutritional supplements and things that make people feel better, we do have to allow some leeway for that. But I think when things about a treatment like a drug, we have to really be patient and try to do it the right way, just like Dr. Kim said, or else we will not be successful and we will not find the thing that works and not learn about the things that are potentially harmful. So I would discourage sort of the mega non-nutritional doses of anything, but I think there's certainly some credence to being healthy and for each person choosing what that means for you in a healthy lifestyle. That's probably my common sense advice.
Other things that you've probably heard from the community.
What about
too.
the vitamin K? That's what she.
Yeah, so I think vitamin K is challenging. Vitamin K is another thing. Nutritionally, vitamin K through our diet is kind of how we get most of those things. Supplementing vitamin K can be very tricky because some people don't metabolize and process it very well. And the downside to extra vitamin K is it makes you bleed. So I certainly would not want people doing anything that could make them worse.
K2 is a blood clot.
So yeah, so vitamin K, the question was sort of, so vitamin K is one of the things that we have in our liver that we make, and it's antagonized by things like blood thinners, like warfarin. So, you know, when patients are on those kinds of drugs, it's very tricky. If you have too much of vitamin K, you can actually clot. So it's balancing between bleeding and clotting risk. And there's not a good way we can necessarily know what's too much, what's too little. And this is the challenge of some of the dietary nutritional things, is how do we know the right amount of anything? So I think a healthy bit of caution. I think do your research, talk to your doctors, do what you can. I will tell you the doctors are just as ignorant. And so I think this is one of the challenges. I always taught when you're buying supplements, talk to the pharmacist, make sure it's not going to interact with anything else you're taking. Talk to your herbalist if you're going to do herbs, make sure you're getting reputable, high quality things. You don't want to put things in your body that you don't trust and don't know anything about. So I think just being mindful of those things, because I do think a CCM patient population is quite vulnerable to trying things when you've been desperate to find something that could work. Just, you know, use your medical experts, knowing that they don't have all the answers either, but maybe they can talk through some advice and some kind of good ways to navigate some of the world that is hard to regulate. You know, nutritional supplements are non-regulated by the FDA. There's no testing for them. There's nothing, no data. And so we do have a little bit of the Wild West of this area that not all things are bad. I think we just don't have a good bar of what's good and what's not good.
Have stem cells been used to treat CCMs or impact regrowths or anything like that?
You might know.
Not that I know. Stem cells for cavernous malformation. We've been using them for stroke, but not for the cavernous malformation, not yet.
But it isn't like a hemorrhaging stroke, that's the same thing, post-bleed.
Well, the idea is typically with the cavernous malformation, if you have the hemorrhages or the microhemorrhages, at least not in the brainstem, in the other areas of the brain, most of the symptom is sort of transient or local irritation and disturbance, as opposed to when you have a big stroke which takes out large parts of the brain. So I could potentially see a use, but not really immediately in that way, the way we are using stem cells for ischemic or the more traditional type of stroke.
I think
So I had a conversation with Dr. Steinberg about this because I keep wanting him to do some presentations about stem cells and the possibility of
hemorrhage treatment to restore some functioning. And what he said to me was, we're only trying it for ischemic stroke at this point. But once this is done, if we have proof of concept and it looks good, then we may continue on to hemorrhagic stroke, which would include CCM. So it's down the road, possibly. But if it's not working, it has to be shown to be working for ischemic before they'll even think about moving it on to hemorrhagic.
Got a question from the
internet.
From the field, yes. Post-op care and monitoring question. Do you do yearly neuropsych evaluation on patients to evaluate deficits? Also, I think this is a question. Do you do yearly MRI for familial patients?
Yeah, so in fact, even the non-familial patients, anyone who's had an operation, he does keep them under radiological surveillance. Usually we do once a year, that can be wherever they are, it can be done locally. And then it comes to our case conference, and usually the fellows, we have a look at it and we discuss it if there is anything that's. So we keep them under radiological surveillance. As for neuropsych, I think it depends upon the patient and how they are postoperatively. You won't do it as a routine, but if it's something that we think will help them, or depending upon where the cath mount was, then we might listen.
Recently there's been a lot of news about CRISPR and gene editing. Is there any thoughts of any trials that, since we have identified like CC1 mutation 2 and 3, are there any opportunities to work for UC Berkeley, since I think they have a center there?
So they were, UC Berkeley was one of the investigators that created the CRISPR system, Cas9 system, and it's mainly being used right now in research settings, in animal models. And I think now for certain diseases, they are trying to start some clinical trials, but I think that's still a little ways away.
Little less than 5 to 10 years?
Well, it's hard to say.
Well,
Yeah.
So maybe the question is, so is there anything going on in China? Because China is testing CRISPR like crazy.
Yeah.
They have way more relaxed laws than we do.
I honestly haven't been keeping up with that literature, so I'm not sure. I don't know if anybody.
Yeah, we can get Amy to weigh
Yeah.
on Amy Akers, our scientific officer. She's been going to things that have to do with that, and we can try and get her to give us some info.
I think CRISPR, it's China's just doing like humans on extreme diseases. People might be getting into the cycle like.
Yes.
It sounded like radiation is less, I don't know if it's like, it's less preferred than surgical or laser. Is that accurate? I mean, and what are the reasons why?
Well, I think it's slightly, with the radiation, there is data, like I said, at least from the Pittsburgh group, who do a lot of radiosurgery for cavernous malformation. But even their papers that were initially published were for lesions that were not easily surgically accessible. The data is, at best, I would say, is ambiguous. It's not as widely accepted to do radiosurgery for cavernous malformation because there are issues with the natural history of the condition and whether really what we're seeing after a couple of years is part of the natural history of the cavern because the bleed rates are so low, as you demonstrated. Or are we doing anything extra by, are we achieving anything by giving radiation? It's not clear cut. At least Dr. Steinberg's philosophy, based on his experience, is that it doesn't really work. And in fact, we've seen patients with adverse effects. And when we have gone in and taken the cav mounts out, which have been radiated, almost certainly on the path exam, when it goes to the laboratory, there is still evidence of good amounts of residual cavernous malformation. So I think it's really, if you were taking a very balanced view, if it was a surgically inaccessible area where the risks are too high, and you wanted to try something, it could be something in a high volume center, which is doing a lot of radiation for these kind of malformations. It could be considered. But it's not something that we advocate sort of straight up front. If we can take it out surgically, we prefer that.
I would say that one of the caveats is one of the mutation, the familial form, radiation actually has been associated with making it worse and causing CCM formation. So there are some cases where the radiation may actually have more adverse events than that. So I think it's an area where it's controversial, but I think there's some kind of boundaries where all of us as a community would say it's probably not a good idea for those familial types.
So I'm just curious, since you've been in this only for a year, is it normal to have only 5-minute MRIs at the follow-up appointments, or what's the norm? Like, would 5-minute MRIs catch anything? That's my daughter gets seen at UCSF in Oakland Children's Hospital, Dr. Peter's son, and we've done one in December. We just did one now last week or this past week, and she seems to be clean according to that. But is it accurate? I mean, should I ask for? I mean, you were talking about the different types. Should I be asking what kind they're doing, or?
Yeah, no, I think, I mean, I guess I was thrown off a little bit. The MRI scans are long. They're usually more than 5 minutes.
Yeah, because they don't want to sedate her because she's 3 years old.
Right, well, I think that's the difference. I think that's the standard MRI protocol, especially in adults, is more like an hour, if not more. And I think with children, it's balancing the risk, especially with such a young child, putting them completely to sleep with anesthesia. And I think that's a risk that there's more risk to doing the anesthesia than actually taking the picture. So I think that it's a balancing act that Dr. Sun is trying to do, to at least give some snapshot and probably looking at the blood sequence only to see if there's a new iron sensitive image to just get away with as quick a picture as possible. You're right, it's imperfect. It's not going to be enough. But given the special scenario there, I think it's, I think we have to be quite flexible and individual, but knowing that at some point when your child is older, and certainly having advice from other folks with young children with this to try to, optimize getting better pictures eventually. But right now it's just a tough time to balance all of that out. Absolutely. We are kind of reorganizing. I've talked to some other folks that, a lot of these, because it's a rare condition, it's hard to navigate even these medical centers. And one of the advice pieces we got from working with the Angioma Alliance is, how do we find the right people and help have some consistency of care and even just getting the appointments and figuring out who to go to. One of the things we're going to be working very hard on at UCSF is to improve our outward kind of face I know everyone I work with, but obviously trying to find a path to one of our group is not easy. And so trying to make it easier for patients to find us and creating a web portal that is much more easier to navigate. So, and we'll include our affiliates in Oakland too, because I think as the Children's Hospital is expanding to other sites, to make it easier to kind of umbrella everyone together. We do a lot of teleconferencing so that folks don't necessarily have to come all the way across the bay every time. But folks do travel, and I think to try to make it worth your while to come to centers on the West Coast, if you don't live around here, or from Southern California, Northern California, we've got to make it easy for folks to navigate and get the best out of the care we can give. And right now, I'm hearing from a lot of folks, that's the barrier. It's just hard to find the right people who are doing the good work. And so I think that's something I personally will take as from this meeting today, is to make it much, much easier on you folks to find us.
We need to go. But she is going to start scanning in a minute. So if you do have additional questions, feel free to email them to me, and I will get them to the folks on the panel, and we'll try to get you an answer back. One more housekeeping thing: if you were in the picture with the UCSF certificate presentation, I need you to sign up your library. Basically, I need you to sign a form that says it's okay for us to use you.
Is there a way we get these full presentations? We post them up on the share site?
Well, so everything's going to be on YouTube, right? So
I think that's
just the actual slides.
Yeah, it's very laborious to watch over YouTube.
Yeah, so it's not going to be